intuitively perhaps, but partly through experience. And there is evidence that when we work hard, we gain a lot. So I'm now moving in the direction of pleading with you that time has come that we not only look at the neurology as a disease, as a discipline that handles the disease, but promotes the highest potential of child's development, child's capabilities, psychosocial, cognitive, language, sensory, and so on, for for the families, for themselves, for the child, and for the nation. I like to bring to your kind attention, and if you have not been, some of you may be aware of Karnataka Brain Health Initiative. This is an initiative which at NITI I had the privilege of catalyzing. Statewide program and with NIMHANS at the nodal point, but very ably supported through budgetary inputs from the government of Karnataka. This is all brain health at all ages. Happy to tell you that they have ensured child being included with particular focus on epilepsy and developmental delays. This is the model that's being visualized as a future model for brain health in the country. I like us to study this. I like the leadership of AOCN to be aware of this. Maybe pay a visit and please help in refining the model from the point of view of the child. This is a model in which training materials have been developed. It talks about brain health clinics at district level. It talks about engagement with specialists as well, because Karnataka has many DMs in neurology. I would like to therefore request you that those of you who may not have heard about it but are looking at solutions for future brain health, including the foundational brain health, which is the most important component of brain health for a human being across life course, child, and child. So we like you to be helpful in this and to be able to refine this model and to be able to promote this model, contribute to this model in other states. I believe this is the future national program on brain health, and this is what has been stated, and NITI had been involved in this. And so these are the opportunities I'm reminding dear pediatric neurologists today, that please connect with the larger picture, not just for advocacy, but more. I'd now like to devote a few minutes to bring to you but largely for the younger delegates, the importance and the pathways for early childhood development care and education. And the purpose of this and you should play the role in this for this great purpose, namely, let every Indian child attain the highest level of cognition, motor, and psychosocial potential. That's our job. Our job is not just to only treat morbidity. Please avert morbidity and then go a step beyond to see that every child's brain, every child's neurological and neurocognitive capabilities are of the highest order in the world. Because if my country, if your country, if our country, on the average for a child cohort of 2.5 crore, loses one IQ point, that's 2.5 crore IQ points, which a neighboring big country doesn't lose, for instance, because they take care of their children. Many countries don't lose. Developed nations have not lost these IQ points. We cannot afford to make our children lose even a single IQ point against the best potential. And I think you have a leadership there. That's your future role, among other roles that pediatric neurologists you may like to play. And that's my humble submission. I made this submission, I think 2022 also, but I'm now highlighting this as the like the concluding part of my submission to you. We must move from detecting developmental delays and acting. No, but to actively promoting positive child development. Our textbook, including my textbook, has been heavily loaded on describing development, fair enough, and then saying, okay, delays and act. We do not talk about promoting positive child development, promoting development and holistic, evolution of the child within the family system, offsetting the adverse, effects of today's screens and isolation, and so on and so forth. That's my plea to you at AOCN today. I want to bring to your kind attention here a very difficult situation that we are in. This is on this side on the graph. If you see the part that I have circled, it shows that a rural school children, and these are class 3 children, only 30% of them can read what is meant to be read by class 2. What does it mean? If I'm in class 3, I must be able to do something that belongs to class 2, right? So 90% of us should do it, or 80, but only 30% are able to do it. Part of this may be schooling, but part of this is surely that the hardware and the capabilities of the hardware are not optimum at this early stage. We believe suboptimal early childhood care development education is a key reason that we are not building on the foundational part. By the way, it keeps going on even at the age of, even in class 8, even the class 8 rural student, only 70, whatever, 2% of them can read class 2. One quarter of them still can't read class 2. So schools will do their job, but are we ensuring that the earliest part of the capabilities, which are biological, by the way, have been nurtured well? And that's the point I wish to bring to your kind attention. You know this better than me, but I must repeat for the sake of young students here that if you look at the brain growth velocity, it is fastest in the in utero period, and then it is still fast in the first 3 years, or okay, let's say 2 years or so, and then levels off. Nerve cells appear at 5 weeks. At 12 to 14 weeks, 15 million nerve cells are being produced each hour, I'm told. Newborns have 1/4 of the brain size. It takes 1 year to double the brain size. At age 3, 80% of brain is done. And at 6 years, 85% of the brain is done. Any difficulty? No. Yes. Okay. Full brain size, 14 years, maturation process goes on further. Earliest phase is so critical. And then what happens is, additionally, that this is the time up to 2 years, 3 years, you can see 3 years in the last, conception, age in months, and then age in years. This is a time when the language is being learned. What am I telling to pediatric neurologists? But this has implication for our work. It's not enough to know. It's also important for us to do. And I'm asking for the doing part. Sensory pathways are done. Language, cognition, all this is the business of first 3 years largely, and then maybe 6 years and so on. We have to capture this moment for the purpose of ensuring optimum cognition. This opportunity, as you know better than me, is biological and does not come back. I just want to again bring something which is so fascinating. I have shown this to the highest leadership in the country. This is the importance of what's going on in the earliest phase. 1,000 to 10,000 new connections every second in the earliest months. 100 billion brain cells. 1,000 trillion synapses at 3 years. 7 to 10 per cell. And as baby grows old, you know it, but I want to say it very loud. Their brain prunes them. That red arrow. The rarely used pathways are gone. So if the music has not been introduced, much of it will go. Very difficult to get it back. Not easy for me to learn a new language. It's just gone, even at the age of 35. I couldn't have done it. The one that you to build on, the one that are used by environment, through interaction, through stimulation, are strengthened. And that's the key. And the team, from 1,000 trillion synapses, only half are left. So the ones that are not used are gone. You cannot catch it up. You again know it better than me. But this has importance of our action and for you to act. And this is a more granular 1,000-day story. We talked about neurulation, migration, myelination, and so on. This is what sits behind those capabilities and the biology. So therefore, I believe that to aim to achieve a developed nation status, intelligent, educated, skilled human capital is of course, the prerequisite. The people which make a country great. And early childhood care and education, ECDC, whatever name you give it, is the foundational building block of this continuum of human capital value chain. Connecting with education, connecting with skilling. Foundation of cognition, language, motor, psychosocial capabilities is laid in the first 3 years in particular and up to 6 years as a very important phase. Learning outcomes are poor and believe that one reason is huge big reason is suboptimal early childhood development when that biology is active. $1 spent in early childhood development brings back $13 at least, and so on. National education policy promotes this. There's a recognition of this at the highest level. The SDG goal encompasses the need to promote ECDCE. Are we doing enough? And that's where we need your support. So we need again repeating paradigm shift in addition to your work of detecting morbidity, averting specific morbidity. I'm requesting you to work on ensuring highest possible development of the child to prepare the child for school and beyond. And what does it mean in practical terms? Starting with birth, skin to skin contact, breastfeeding, kangaroo mother care, and more. Responsive feeding, conversing, communicating, loving, talking, playing, sensory stimulation, motor activity, reading, group activities, and secure home environment, support from the system, local language, parents' role, toys, technology, and more. This is how the framework emerges, and we can build on this. I want to bring to your kind attention, it's a research meeting very briefly, a work done by Dr. Subodh Gupta's team at Wardha. They did a project called ARAM in Maharashtra. Their interventions were use of a mother and child protection card, counseling card, parenting guide, focus on 0 to 3 child development, 0 to 3 early childhood development, monitoring tools, video film facilitators guide. Their interventions including talking to mothers in groups using flip chart, home visits by frontline workers, parenting workshops in groups, building a social norm, making obvious to the people, to the communities, to even educated people, the importance of child development and what it takes to ensure that, which every family can and should ensure. Then mobile phone messages is a strategy that they use. They engaged with the community norm for child development, brain banana, दिमाग तेज करना, ये norm और इसकी बात हमारे आज तक नहीं होती. We never have seen a hoarding on child development. कभी एयरपोर्ट से गए हैं किसी भी सिटी में, child development which is so fundamental हमने कभी obvious नहीं किया हुआ. This is the brain wiring games that they have devised. I'm very proud of this work. And customized messaging, home, age-specific messages, peer learning, community norm building, and then of course using health facility opportunity. They demonstrated that when you do this, the home visits improve because they engage. Of course, it should improve, part of the research. Parents' meetings happen, dietary frequency improved, dietary diversity improved, responsive feeding in which the interaction improves, play activities improve. For us, today's discussion is that you are able to improve the processes. What is very important is that they demonstrated, and that's research, significant improvement in development and social quotient by as many as 20 points and by some 10 points respectively. So to demonstrate that the change can be achieved systematically. I'm very also proud and happy, and I'm complimenting the team, Dr. Beena Kosh's team, CMC Velo. She has shown that structured early childhood education exposure leads to better IQ, clearly. And this is a great work, and I like her to be playing a role with you all for research and more. Maybe you already are engaged. She has demonstrated that you can actually, this is not an intervention by improving the child development part, but in a structured way, but in the existing system. It shows 7 IQ points, and 7 IQ points is hell of a lot. And the 7 IQ point opportunity they wrote is sort of there for us to harness and more than this. And each IQ point, by the way, gives a lot of income dividend and productivity dividend and so on, not going in that direction. It's worth it. And I'm sure with better ways of doing it with science, doing it with technology, doing it with the emphasis that's given by pediatricians as doctors, because the doctors are seen as the final word in advice and so on. I'm sure there's so much more that can be done for our children to bridge their potential compared to every other, children in every other well-developed nation. Based on then, it's my feeling that we need to achieve an optimum early childhood development mission is to work with families, is to make our Anganwadi system and Balivatika system even more vibrant. Peer learning from each other work very nicely in Aram, and it makes intuitive sense because when the mothers sit together, look at the child who's doing better than that, the other child at the same age. Creating a community norm is fundamentally important. Detecting development delays is, of course, fundamentally important. Special situations are often neglected, and there is a role for us to play. And creating a people's movement is needed to achieve this. I just want to make a mention here that among the special situations where you and I have a role to play is, of course, in pregnancy, in facilities, in outpatient. Are we using our outpatient opportunities for more child development? Are we using newborn units for early stimulation, nurturing care, kangaroo mother care? Are we engaging the families of non-acute care inpatients for promoting child development when it matters? And what about ensuring the care of children who are delayed and so on? So there are huge opportunities for us to play the role even in our own practice. But my ambition and my expectations are higher, and I'll come to that to you in a minute. We have this tool which we give to every child called Motherland Child Card. It has beautiful description of child development activities by age. We don't even look at it. We don't tell our students to. We don't tell our nurses to kindly show. We don't use it when the child comes to us for anything. Just as a child who's seen by us, by me, by you, उसका हम बदल लेते हैं. कहने के लिए डेवलपमेंट में वो चल रहा है ऐसे कहते हैं, लेकिन पॉजिटिव नहीं कहते कि अब क्या करना, उसको बेहतर से बेहतर नहीं कहते. I repeat, I am taught by my teacher, every child check the weight, every child check nutrition, check immunization, check development. Hopefully be a promoter. Check development means हाँ चल, हाँ बोल. What should we do now that he is among the very best? We don't say. That doesn't come. We advise on the next immunization dose either. But we don't. This is not incorporated into pediatric fraternity and our students and our residents and then we have this chart being given to everyone. Please think about this. That's about nation. These are the depictions of different ages. Then there are other material, digital tools are available. They're coming by the day. So much is available that can be judiciously used. Child development, delayed detection has been, of course, a lot of work has been done by our fraternity. We have such charts. Again, picks up the delay, but when normal to do more, and when delayed to do even more, that part is weak. We don't talk in terms of toys. We don't even know what the toys are there in our, in our region or in our context, and so on and so forth. So, if we have to do this for our nation, a lot of people should do this to promote child development. But pediatricians have a role to play, and you have a role to provide leadership. Now, this is my summary slide for my asks to you. This is for AOCN and for pediatric neurologists. As professionals, can we make a super habit that ECD will be talked about in our personal, professional interaction with with patients in the clinic, beyond illness, beyond disability, beyond responding to only the problem? Positive messaging. हम आप नहीं करते. Number two, collective. You have a role as AOCN to promote positive child development. That's the foundation. Most children are normal, but can they become from the normal to the very best in the world? We don't do this. I urge you to do that. create a small group that works on these things. And I'm coming to some other things that you will do with it and promote this. Make it a visible agenda. It's not only about mobility. Promote the simple use of MCP card to start with. And show this in, conduct many workshops on this and so on. In terms of knowledge, promote education in ECD to medical, nursing, and other professionals. We don't do it. We may perhaps have classes on nutrition and feeding and so on, but child development, no. We don't do this as a workshop with our undergraduate students as we do for neonatal resuscitation and environment. Track the science of ECD, which is changing. Inform profession. You have a lot to tell the policymakers to improve the program that I mentioned. I told you that they are not optimum at times. Contribute to scientific advancement of child development. I'm sorry to say, but other than the two examples, Aram and Dr. Beena Kosh's work, I'm not aware of any, and pardon me, I'm not claiming that I know everything, but what are the other major researches done in this area, by the way? Let me know. Can we create a consortium for research? इसमें भी तो रिसर्च हो रही होगी, बच्चों से बेटर कैसे करना, डिफरेंट डोमेन्स में कैसे चीजें लेके आना. No research, to my mind. Even from biology, perhaps I'm not, but pardon me, I'm not claiming this to have the full information. I'm impressed with these two researches that have been done, Aram and Beena Kosh's work, and I hope Karnataka has a learning for us in this sphere as well, perhaps. Develop family-centered models, demonstrate their effectiveness. That's your research. Research on how to use AI for early childhood development. This is an opportunity waiting for us to do it. AI can watch a child's behavior for 3 minutes and tell you a lot. AI can be an assistant to you to have targeted ECD coaching for the family and to the doctor, first and foremost. But there's so much more. Perhaps a huge lot more with robotics and everything. ये कौन करेगा? कोई और करेगा तो हम कहेंगे फिर adapt. This is our opportunity. And in terms of program, as being the leader of the brain health of children, please provide support to state government. Please engage with them. Please promote this angle as well as, of course, issues of Divyang children, issues of development delay, the epilepsy, the rare diseases and so on. We all have to do it, but I don't hear early childhood development being promoted by pediatricians. And therefore, may I request you to please, one way to look at this is perhaps to see through the lens of the agenda of pediatric neurologists to focus on preventive pediatric neurology. Have you been talking about this in your fora, in your meetings? If yes, please build on this. If not, this is not an opportunity to be wasted. Way back, cardiology, 80s, started to foray into preventive cardiology. People would laugh. And today, the only way to prevent, to really make a difference to CVD as a public health issue, among other NCDs, is prevention, prevention, and prevention. Primary, if possible. Secondary, if need be, in the cardiology CVD field. For us, we need to build a positive child development revolution and a movement in our country to be able to have a human capital that will deliver in this generation, millennials and Gen Z generation, your job to ensure that we deliver a Viksit Bharat in which every child and therefore eventually every adult has the highest brain capital. This is one part and the crucial part of brain health. There are other aspects, indeed. We are mindful of them, but I think this part must get your urgent attention because this is the foundation on which the child's capabilities and the nation's capabilities are built. And because we will act early, very early in the life course of the child, beyond health and nutrition, beyond mobility, you can actually change the story because in the starting of the story, the whole story of the child's life will change if those capabilities are promoted, are energized, are supported, are catalyzed, and are allowed to unfold and bloom and nurture. Thank you very much, Jai Hind.
Thank you very much, sir, for this enlightening talk. Professor Kalra, ma'am, can I just speak 1 or 2 minutes before you lead the
Um,
discussion with
I'm
the group?
sure you all agree. Vinod, it was
Ma'am,
most
ma'am,
wonderful. You brought us up to date with what the current situation, the evolution in the country, how we've missed our role, I would say. I think it was soul stirring for me as to what we've not done and what we really need to do in a more positive manner. And anyway, it's an ongoing opportunity. And I think it really should kindle the lamp for such activities to be brought in line by the people who are in the profession. And I understand also that the kind of linkages you talked about, information about good studies, information about good experiences that should be shared with the government, and also utilizing the government system, which has been upgraded so beautifully, should be brought in our daily practice. I really thank you for this very, very nice talk and wish you a belated happy birthday from all of us.
Good.
It's
Thank
now open
yeah,
to
ma'am,
the.
Kalra, ma'am, can I just make a comment? Am I audible?
Yes,
Kalra,
yes.
ma'am? Yeah, yeah, name, ma'am. Thank you very much, sir, and for accepting this. It's great honor for us, and I apologize to my friends in the hall that I had to come back to Delhi yesterday. Wanted you to know that Dr. Kalra is my mentor number one. Professor Paul is my co-mentor with Dr. Kalra. He's taught so much in life in the last 38 years to us. Besides being a global icon for neonatology, he's a global icon for public health, and we were so honored and proud that he has changed so much in Niti Aayog, being the first pediatrician who went as member, honorable member Niti Aayog, and has revolutionized the public health from pediatric point of view in the last nearly a decade for his 2 terms. So we are really honored and indebted. And in all your teaching, sir, you used to teach in pediatrics. Yes, our mission is obviously clinical care, academics, and research. And and you have always said that nutrition and development are two integral parts of pediatrician, whichever super specialty you go to. And we all, as Professor Kalra there, as the founding president of AOCN, I privileged to be a founding member of AOCN, and the immediate past president with the current president Lokesh Lingappa. We are, at from AIMS we started this, that we have a mission that each child reaches his or her maximum potential, and we are not waiting for development difficulties or challenges from coming up. We have to ensure that, and there is a current work, sir, we are doing with WHO in making a primary, secondary, and tertiary healthcare setting, trying to screen these children. Those who have high risk, they are going to be given, if they are going towards autism or CP side. We have made rehab programs and videos for those, and those who are going to be not having any high risk to have nurturing care. And sir, also not we go by that first 1,000 days, but as you have already taught us, we have to work from a public health point of view to improvement the child adolescent health of these girls, and the vaccination, nutrition, anemia, everything has to be corrected from adolescent girls who are the future mothers, because we don't have planned pregnancies in India in that situation. So we start from the adolescent girls and leave the cycle. And I think with the help of this was a mission from AIMS, and now with the help of AOC and India, I think, sir, we may be able to do, and under your guidance and leadership, sir. And really grateful to you, ma'am. You can lead the discussion in the hall, ma'am. Thank you very much.
Thank you, Shifali. It was nice to hear from you. It's very nice that you are putting in so much effort in that direction. Uh, any any comments from anyone particularly who would like to make some add some information to initiatives that any state is introducing, or any major studies anybody has initiated? Yes.
Thank you, sir, for that wonderful introduction to what the government is doing. Is there a way, as an organization, we can give our inputs in a structured manner to any of these programs?
Of course, yes, of course there is an opportunity. आप पहले अपना वो बनाएं, what else would you like to, what you may like to communicate to the government, and there are pathways, and we're happy to assist you offline in this regard. Um, of course, because all these documents are being made in any case by experts. You will be on the table. लेकिन थोड़ा पब्लिक ओरिएंटेशन से सोचने का भी करिए और एडवोकेसी के अलावा काम भी करते हैं. रिकग्निशन तब मिलती है ऑर्गेनाइजेशन को जब वो सिर्फ एडवोकेसी करें, वो एक लेवल में मिलती है आपसे, लेकिन इस एरिया में काम भी करते हैं. जो भी करना कल आपने ब्रेन हेल्थ बाकी एस्पेक्ट्स हैं, इफ यू हैव आइडियाज do present the work that you've done, put it in the annex, put it visible by your conversation. And of course, government is making these programs only with the help of the experts. No program happens. Sure, we'll find a way. And of course, it's tough. It takes time. It needs consensus. Because कई बारी हम ही लोग जाते हैं कुछ बताने, फिर एक और ग्रुप जाता है वो कुछ और कहते हैं. इकट्ठा होकर जाना चाहिए, कंसेंसस से बना के जाना चाहिए, well articulated होना चाहिए, evidence based, or it is not verbal because you are not there in every room. What counts is a great brief that you make, and that makes, that should be available for people to help. Be happy to help you.
Sir, I just pitching in, sir. I want to remember Professor Bhan today because he is our research soul of research for our department and our country. And I think, and you are, I mean, you were beside him with all of the things. And but the research, he was totally like even in the ward rounds asking evidence for everything we used to do. So I think we have to use that example to trigger research. Otherwise, I mean, this is for public health is one way, but one thing which has to be done together. But for others like who are there as residents and other colleagues, that we have to think even in the general practice in what we are talking about clinicians. He used to always ask her in the, if you remember in our, he was your colleague and friend, but for us, he used to always ask for whatever we give in treatment, what is the evidence for it? So I think we have to keep triggering our brain and to answer, as you were saying, good research questions. And I think as an association, we wanted that we do. And actually, Lukesh gave me the task to head the working group in which we are deciding the 3 areas where we are going to work. So maybe again I can come and discuss with you before we finalize and I in the group so that we do something so that public health can be done. Because you have to have the cognition is important of everything, and as 1/5 of the Delhi is by pediatric neurological conditions as well. So from a public health point of view, there's a lot we can.
Without overstatement, I want to just mention that the National Neonatology Forum has driven the entire newborn health, shall we say, programs. The district newborn care program in the 90s, facility-based newborn care, home-based newborn care, and so on. So you need to systematically work on your leadership and present things as the, step by step. First priority, then moving to the next level and so on. And of course, you have a great role. That's what I'm actually requesting you. But not just advice. ये कर दो कर देना, काम भी करके देखो. आप दिखाइए एक जिले में, आप दिखाइए 10 साल मशवरा आरोग्य मंदिर से, वो भी करिए. आप रिसर्च करिए.
Voice.
Which will then get by the government, but even, and therefore there's a whole world outside just the national programs. You have a direct reach to patients and people in a democratic system. There's a lot that you can reach directly also. So the sky is the limit for you. And as we know, neurology and the brain health of the child is the priority for future. Right? Infectious diseases will go. Newborn survival is now reaching a very heartening point. And the issues of residual problems are more. Okay. Pneumonia, diarrhea, infections are, they're declining. What is coming for future? Endocrine, cancer, neurology. And perhaps yours is the most important. This is rise to the occasion. Think about prevention, promotion, positive brain health. There are other positive. By the way, child development is intricately linked to the autism issue in a way, and you can actually show that. You can create an Indian model of how this is to be addressed, just as we did for, I don't want to go back. The global model in MDGs and was an Indian model. So please pay attention to this. Okay, and beyond this, of course, other aspects of community and preventive.
So your prevention, which you're saying, we are focusing on prevention, primary, secondary, and tertiary prevention, because what we commonly do in the clinical service is the secondary prevention, trying to diagnose early. Primary, we are trying to do research so that we come to know that we can prevent. And obviously, tertiary one is the rehab. But sir, we also need support from the government for the primordial prevention, so as to make the society more humanistic and more, logistically feasible for every neurodiverse child. So I think they will be, they will have to work under your guidance collectively with the government to ensure that each and every individual reaches his or her maximum potential and can lead a life with dignified life in this society, sir, with, and work fruitfully for the society.
Dr. Lakshmi, do you want to make a comment?
No, I've just joined in. Sorry. Yeah.
Okay.
Yeah.
Right.
Thank you.
Okay.
Thank you.
So I think,
Thing is, look at the, what we're building with Ayushman Arogya Mandir is one way to say, but then India is building with most comprehensive family healthcare ever made on this planet, right? That is the expand service. This is work in progress. It's not complete. All the 12 components are at different stages of evolution, particularly the new ones, including pain, mental health, EMT, elderly care. We need help to create these functional models and show that they can be implemented. What does it take to implement them optimally? How to improve it further? तो उसमें कैसे रोल हो सकता है न्यूरोलॉजी का या pediatric more advanced pediatric care using the health and wellness center as the outpatient hub and CHO playing the rightful role. CHO is there today, is not, she has more time today. कल को वो बहुत बिजी हो जाएंगे, सीनियर केयर भी करना है, आई भी करना है, टेलीमेडिसिन भी करना है. How can we utilize that for child, for child neurology more than what is doing today? उसकी मदद कौन करे, वो मॉडल कौन क्रिएट करे, एकेडमिया ही तो बताएगा. तो जुड़ना है आप सबको और पीडियाट्रिशियंस इन जनरल को जोड़ना. There is a revolution going on. I don't want child to get left out of this revolution because other priorities will then be, overwhelmingly being delivered. Well, thank you very much. I hope this was useful, and thank you for
thank
the
you
opportunity.
very much. Thanks a lot.
Thank you, sir.
Thank you. Okay, thank you very much. I do some of the work.
Uh, okay. Uh, Thank you, everyone. For our next session, there's some as well.
Dr. Shifali to give a few words.
I request Dr. Shifali, madam, to speak a few words on the new body installation committee. Madam, if you're online.
Yeah, I'm online. I will remain till the end online. Yeah, I'm there. Yeah. Uh, Good morning, everyone. It's a great pleasure to introduce we did have a handing over ceremony, 15th of
Shifali,
February
ma'am.
this year. Yeah, I'm speaking. Can you hear me? I can speak. Can you hear me?
Yes.
Yeah. Uh, can you hear me? And I know, Lakshmi, I'm saying there, they don't think they cannot hear me. I'm there. Lokesh just called to say, they decided to do an official installation. I'm just writing in the WhatsApp here.
Yeah, for next talk,
Can I,
I
can you,
request
can you hear
Dr.
me?
Lakshmi, madam,
Can you hear me?
to please share her slides.
Can you see my slides?
Yeah.
Yeah. Should I speak?
For this session, can we request the moderators, Dr. Abhishek sir and Dr. Ravi Kumar sir, to be on the stage, please? Lakshmi ma'am, can you hear
Yes.
us if you're there online?
Yes. Yes, I am. Can you see my slides? Hello, can you see my slides?
Dr. Lakshmi, I can see there is an issue there because they asked me to speak something. They was having that installation. We had it online. This was just physically they did. So Lokesh asked me to speak. He had called me, but I think they couldn't hear us when I was trying to speak, right? They didn't. I think they can't.
Right.
I'm just calling them and telling them.
So we'll have a short tea break as of now. We'll join back in another 10 minutes by 10:50 a.m.
I'm just calling and telling. Dr. Lakshmi, hear me? Dr. Lakshmi, there is some issue there. There is some issue. They'll just get buying it because when she asked me to speak, they couldn't hear me, and I just told that you can't hear ma'am also. So they just fine, and that's why they had a 10-minute break. Lokesh has told me to convey to you. He may also be calling, but I told I'll convey.
Ma'am, excuse me, ma'am,
That
we are
there will
able
be 10
to.
minutes. So Beta, you logged. There are two outputs in the same horn.
Hello, ma'am.
Yes.
Yeah, we'll be.
Can you hear me?
Will
Okay.
yeah, ma'am, we'll be resuming the session in 10 minutes, ma'am.
Sure, sure.
Once we sort the technical issues.
You want me to
Meanwhile,
stop
we have
sharing?
announced.
Uh,
I can see your slide, ma'am.
So shall I leave it there?
Yes, ma'am. Leave it there. We'll resume
Okay.
in 10
Sure.
minutes.
Whenever. Yeah. Thank you.
okay. Okay.
Is Shifali ma'am there? Shifali ma'am, can you hear us? Shifali ma'am, can you hear us? No, Shifali ma'am has to make a comment first. So first comment, then you have to. Then we'll. Yes. Shifali ma'am, can you hear us?
Yeah, I can hear you now. There was something
Uh,
problem. I could not hear. Yeah, sorry, but I could.
Sure, ma'am.
Yeah.
I'll give you a cue.
Yeah.
Then you can go ahead and
Okay.
just a statement regarding the committee.
Regarding which
The formed committee, ma'am.
Okay, the form committee. Okay, fine.
Yeah,
No,
I'll give you a cue.
the installation is done.
Yeah, done, ma'am. It's done.
Okay, fine. Okay,
Just
that
when
time you could hear
everybody
me.
assembles, I'll give you a
Yeah.
cue.
Are you just asking that EW1 ka you have to just say? That is what you said? Or you wanted, I thought Lokesh was saying to make a statement for the AOCN thing that time. I don't know. You want me to say the EW1, the three things what you have thought of? That's what? Or what?
No, ma'am. This just one.
This is just for the new AOCN body, just your
Yeah.
wishes, Shifali.
I know. I was saying hello that time he couldn't hear me. Yeah, you guys could. It's okay. Yeah, thanks.
Yeah.
You've done the, yeah. Fine. I'm there.
Yeah, you can do that now. Then we
Okay.
can go to the
Then
session. Yeah,
Lakshmi can
please.
start. Yeah. Good morning, everybody. We had the official handing over on 15th of February this year, which was online because we didn't have an AOCN meeting this year because of the AOCCN last year. So now I welcome the new committee with the head, with President Dr. Lokesh Lingappa and President-elect, is Mahesh, who continues from the Secretary to the President-elect, and all our new EB members. We'll be there, Prashant being the treasurer, Naveen would be general secretary, as you all know, and Arushi, and we have Siddharth, and we have Prashant Utage again, and we have Sashmita Devi Agarwal there, and Ranjit, and I think we have a very dynamic team to take the vision of AOCN forward. Way back in 2002, when Professor Kalra established it in her office in AIIMS, New Delhi, from that time till now, in 24 years, it has really grown by leaps and bounds, and I think we can collectively work. And I continue as the immediate past president in the current EB, always there, and we collectively work for child neurology and have more global collaborations with Lakshmi and Dr. Biju being here, Lakshmi heading the ICNA. I think we can make a lot of difference with the lives of the children. As what Professor Paul said, that we have to make each child reach his or her maximum potential, because the cognitive potential is ultimately going to be the workforce and all in the future. So I think with the coming up long global collaborations with Lakshmi, Dr. Lakshmi's presence, and I think we can move forward. And thank you so much. Back to you, Lokesh.
We'll go ahead. Thank you, ma'am, for your kind words. So we'll be moving on to the next session. This is regarding global collaboration opportunities and the challenges. For this session, I would like to call upon Dr. Abhishek sir and Dr. C.P. Ravi Kumar sir to moderate the session. The first talk will be by Dr. Lakshmi ma'am. This is regarding the interest areas of international bodies and Indian data and AOCN participation. Over to you, Abhishek sir.
Good morning, everyone. So, Professor Lakshmi Nagarajan is a child neurologist and epileptologist. Professor Lakshmi's clinical, teaching, and research activities span a wide spectrum of neurological disorders in childhood, with a focus on epilepsy, neonatal seizures, and EEG. Over to you, madam.
Hello, I'm Lakshmi Nagarajan, and thank you for that introduction. I'm a child neurologist and epileptologist from Perth. I'm also the president of the International Child Neurology Association at present. Thank you very much for inviting me to be part of this meeting regarding the AOCN National Neonatal Hypoglycemia, a Brain Injury Registry Initiative. I have to say congratulations. It's a very exciting area to look at. It's an area that does need more information. And in a country like India, where hypoglycemia is said to occur quite frequently, it's all the more relevant. When we have a national neurology registries, what they aim to do is gather data, track nervous system disorders. It helps us get a good idea of the incidence of specific conditions and also the severity of the conditions. It gives you a chance to monitor treatment and look at the spectrum of outcomes that are there over time and how they change over time. It can help drive research. It helps provide comorbidities, information on the comorbidities. It may also provide very useful data to try and prevent the disorder and improved outcomes from that disorder. It's a powerful tool to advocate for the individuals and families affected by a particular disorder. My own involvement with the national registries in Australia has been with the Australian Pediatric Surveillance Unit, the Australian Neuromuscular Disease Registries, and a little bit with other neurological registries in Australia. The Australian Pediatric Surveillance Unit is a national resource which was established in 1993, and it provides or facilitates active surveillance of uncommon and rare childhood disorders, complications of treatment, or adverse effects of treatment. And the APSU has a relationship with the college, which the Royal Australasian College of Physicians and the particularly the Pediatric and Child Health Division of this. We are all mandated to provide information when for any of the conditions that are being looked at by the APCU at that point of time. The information is strictly de-identified and it's collected by pediatricians for general surveillance. However, if there is identified data that's needed occasionally, for example, when we were looking at the fetal alcohol spectrum disorder, then there is opt-in consent that is necessary to do so. I've also been part of registries run by the industry, for example, the Vagal Nerve Stimulation Registry, which was an international registry. And there are many issues with registries or many aspects that one needs to think of and be careful about. The question is who owns a registry and whose responsibility is the registry? Who pays for it? They are difficult to maintain. What data is collected? Who inputs the data? And who has access to the data? And who decides who has access to the data? Who gets credit for the work? Whose name is on publications from the registry? Consent, if it's totally de-identified data, can it be without consent? But if there is any data that can identify a person, it has to be with consent. Some registries use information the person themselves or the parent puts the data in, so there's implied consent. However, when you think of disorders that start in childhood, say the parents give consent. When the child becomes an adult, do you need to reconsent? These are all things that we have to look at. And data safety is a big issue. Databases can be broken into, and data sharing. Who will you share the data with? Again, who decides who you will share the data with? And ethical issues and social issues have to be looked at very carefully. Global registries are very useful and they connect individual registries. So it's very good for each nation to start their own registries for different neurological disorders. They facilitate research and help establish guidelines that can be used across the world instead of just in one place or the other. And certainly may be able to advocate for better services and for research in that area. In neonates, hypoglycemia should be considered a medical emergency. It can cause seizures, it can cause encephalopathy, it can also cause permanent neurological damage, and in rare cases, death, if not picked up early and treated adequately. Hypoglycemia in the neonate is frequently observed. It occurs in association with hypoxic ischemic encephalopathy, other metabolic perturbances like hyponatremia, hypocalcemia. In a critically ill neonate, for example, an infant with sepsis, it occurs at a higher frequency in infants of diabetic mothers. In growth-restricted babies, premature babies, is associated with hyperinsulinemia, may also be associated rarely with metabolic and genetic disorders or inborn errors of metabolism. The area is very complex. As in postnatally, the glucose falls, reaches a nadir at about 1 to 2 hours of life and goes down to 25 to 30 milligrams per deciliter, and most often is asymptomatic. Glucose concentrations then stabilize at levels higher than 36 milligrams per deciliter by 4 to 6 hours of age, regardless of feeding. And studies of healthy, exclusively breastfed neonates have documented a wide range of glucose levels from 18 to 166 milligrams during the first 6 to 72 hours of life. Brain injury, however, has been seen over a range rather than in a single blood glucose concentration. And the safe limits of hypoglycemia or blood glucose levels that will prevent neuroglycopenia and neural injury in the neonate are not really known. And hypoglycemia can be symptomatic or asymptomatic. It can be mild, moderate, or severe. Severe or protracted or recurrent hypoglycemia is more likely to have effect on neurodevelopmental outcome. However, there's no straightforward relationship between the low glucose level, the duration of hypoglycemia, and the adverse neurological effects. So then a lot of work needs to be done, and a registry which gathers information would be very useful. Early feeding is the optimal initial approach. Dextrose gel, IV dextrose, sometimes glucagon, steroids, and something else may be necessary. Obviously, identifying the etiology is very essential because then you can have targeted therapy or precision therapy for that particular baby. This paper from India on epilepsy was very interesting in that they said the leading cause in their cohort of 231 children with epilepsy onset less than 5 years of age was structural brain injury, most often occurring at the birth time or soon after. And among the identified causes that cause this brain injury, neonatal hypoglycemic brain injury emerged as the most frequent contributor. And what was worrisome was that in 50% of the babies who had this hypoglycemic brain injury, they were in the low risk category, with predominantly male infants born to primigravida mothers. And that neonatal hypoglycemic brain injury emerged as the most frequent contributor to the epilepsy. Keeping all this in mind, and being aware of the many challenges in variability, definition, treatment outcomes, and that neonatal hypoglycemia may have adverse effects on neurodevelopment that may not be apparent at 2 years of age. You need to follow them at 5 and 6 and 12 and 15, because some of it may be on subtle executive function or subtle parameters that you cannot pick at 2 years of age. So carefully designed randomized trials are required to determine the optimal management of neonates with hypoglycemia with long-term follow-up at least till school age and preferably to adult age. And identification of effective strategies for prevention is very important because that should be our ideal strategy. And national registries may be very helpful. And the National Hypoglycemia Brain Injury Registry that the AOCN has taken the initiative with is wonderful. And there's no single, as far as I'm aware, there's no single universal registry dedicated to neonatal hypoglycemia. There is a Children with Hypoglycemia and Developmental Outcomes Registry based in New Zealand and registered with the Australia-New Zealand Clinical Trials Network. A lot of neonatal data sets and information from NICU admissions and follow-up have provided useful information, but a registry that gathers data across the country, across regions, across socioeconomic groups would be very good. And I congratulate the AOCN on this initiative and wish you all the best personally and from the International Child Neurology Association. Thank you.
Thank you, Dr. Nagarajan, for finishing on time. Just a quick question. You mentioned about no relation with hypoglycemia and neurodevelopmental outcomes. Is it based upon the data from your New Zealand registry?
No, there is. data with neonatal hypoglycemia does cause problems with development, but what level and how long, and does it have to be severe? Does it have to be less than 2 millimoles? But can it be between, can it occur at 2.1 if it's there for 12 hours? We don't know all the details. You can have it sometimes even with mild hypoglycemia. You can have the neurodevelopmental outcomes that are impaired, and you may not pick up the more subtle neurodevelopmental impairment at 2 years of age. You may need follow-up studies later in life.
Okay, thank you. And secondly, this registry, what you already have maintained, is it publicly accessible? Is there any learning points which we can take it from there because we are starting fresh?
I'm sure I can put you in touch with the people in that registry.
Okay.
It is based in New Zealand, not in Australia, but there are publications from that registry that have provided the outcome data at 2 years and then later showing that some particular aspects of executive function may be more impaired even with subtle hypoglycemia.
Okay.
Or
Thank you very
language may
much.
be more impaired in some situations here.
Thank you very much. I'm sure Dr. Lokesh will get connected.
Yes, thank you.
Thank you.
Just a small announcement. We had 6 different expert working groups yesterday. So in the next session, we would like one representative from each group to make a recommendation. This recommendation, either you can do a PPT or come to the dais and give out the recommendations. Thank you. This will be after 3 talks. Thank you so much.
The next talk is by Dr. Biju Hamid on global collaboration in pediatric refractory epilepsy, opportunities and challenges. He's online?
Yes, I am. Yeah, thank you. Let me just share. Thanks.
Dr. Biju Hamid, consultant pediatric neurologist and head of pediatric neurosciences at Mubadala Health, Abu Dhabi. Dr. Hamid has previously served at Gauche and Bristol Royal Hospital for Children in the UK and is internationally recognized for his contributions to pediatric neurology. Over to you, sir.
Okay. Thank you. Thank you, AOCN, for the kind invitation. And thank you, Lakshmi, for setting the scene. I've been asked to talk on global collaboration in pediatric drug-resistant epilepsies. So when it comes to international collaborations, it's not going to be judged by the number of organizations that AOCN has entered into a memorandum of understanding with, but it will be judged by whether AOCN develops stronger investigators, more capable centers, higher quality evidence, and more equitable pathways for children. So the neonatal hypoglycemic brain injury registry is the beginning of that journey that AOCN has set on. And pediatric drug-resistant epilepsy shows how that architecture could scale to complex, multidisciplinary, and time-sensitive disorders. So I want to argue that while global collaboration in pediatric drug-resistant epilepsy is necessary, it need not always be automatically beneficial, because when it is done well, it builds permanent national capability. But if it is done carelessly, it can produce data which can look comparable, but when it is not. So the question, therefore, is not whether AOCN should collaborate internationally. The question is on what terms AOCN should collaborate, some of the points which Lakshmi has already highlighted. So I will structure this talk around 4 points. First, the gap. Secondly, the 5 challenges that decide whether the data mean anything. Third, the 5 opportunities that collaboration can realistically deliver. And finally, what the first 2 years should produce. So around 50 million people worldwide live with epilepsy, and nearly 80% are in low and middle income countries. And in many of these settings, the treatment gap exceeds 75% because of limited access to medicines, EEG, MRI, specialists, and epilepsy surgery. And about 1/3 of people with epilepsy develop drug resistance with major consequences for development, education, quality of life, and mortality. India carries an estimated burden of around 10 to 12 million people with epilepsy, but access remains highly unequal, particularly in rural areas. The children are widely distributed while specialist services are concentrated in very few centers. So therefore, the priority is very clear. Earlier diagnosis, stronger referral pathways, wider surgical evaluation, national registries, teleneurology, workforce development, and equitable international partnerships that translate data into better access and better outcomes. So this infographic summarizes a recent systematic review from AIIMS Jodhpur on pediatric and adolescent epilepsy in India. And the key finding is an overall prevalence of 0.8%, or about 8 in every 1,000 children and adolescents with epilepsy. And there is marked regional variation from 0.4% in central India to around 2.3% in the northeast. And the study, importantly, has also highlighted substantial heterogeneity and a persistent treatment gap. So the message is clear. Epilepsy is an important public health issue in Indian children and requires earlier diagnosis, better access to care, and age-specific services. So roughly 1/3 of people with epilepsy will become drug resistant. And in children, it is front loaded because the developmental cost of uncontrolled seizures is highest in the first years of life. Secondly, about 4 in 5 people with epilepsy live in low and middle income countries, and resource limited settings up to 90% may not receive adequate treatment. And thirdly, in a well-resourced US community cohort, an estimated 127 children per year developed drug-resistant epilepsy. And of that, about 52 per million reached a comprehensive evaluation. And of the 52, about 27 underwent an epilepsy-related surgical procedure. So in other words, roughly 4 out of 5 children, even in a setting where resources existed, did not reach definitive treatment, which shows that although the disease is global, the capability is not. And Jorge and Vidore and colleagues had argued that the main barrier to epilepsy surgery in lower resource settings is not lack of evidence, but limited funding, infrastructure, trained teams, and timely referral. And this paper did not examine India directly, but the framework is highly relevant. India needs a tiered national model, regional centers beginning with carefully selected lesional cases, linking it to high volume hubs through training, tele-EEG, and shared protocols. That collaboration should build sustainable Indian capacity. So the framework that I want to put is, do apparently comparable data actually describe comparable children, comparable investigations, and comparable opportunities for treatment? Because a child recorded as drug resistant in one center may not meet the same criteria when independently reviewed elsewhere. A scan which is recorded as normal may be a harness protocol study led by an expert pediatric neuroradiologist, or it could be a routine sequence with no adherence to any epilepsy protocol at all. A child recorded as not a surgical candidate may be the conclusion of a multidisciplinary team, or it could be the consequence of there being no surgical service. So the point is again simple. The same field name in the same database can carry entirely different meanings. So everything that I'm going to talk next follows from taking that seriously. So 5 challenges that decide whether the data mean anything. The first is the definition. So the ILE definition of drug-resistant epilepsy is failure of adequate trials of 2 tolerated, appropriately chosen and used schedules. In practice, the words adequate and appropriate travel very badly because an yes or no checkbox for drug resistance would be the single most dangerous field in that registry. The second is the capacity. If a missing genetic test and a negative genome are recorded identically, then the analysis is going to be meaningless because every investigation needs a value set that separates performed from negative, from indicated but unavailable, indicated but unaffordable, declined, and not indicated. Thirdly, the denominator, a registry restricted to children who reached surgery, cannot show where children were lost in the pathway. So the denominator has to start at the point of meeting criteria, not the point of treatment. And fourth is governance, which Lakshmi has also highlighted. These are sensitive longitudinal pediatric data, often including video, imaging, genomes. So the consent, assent, reconsent at maturity, custody, and international access must be settled before that first child is enrolled. And lastly, sustainability. Because grants build registries, almost nothing will fund the coordinators, the translation, the audit retention, and migration. So a registry that depends on one grant, one vendor, or one enthusiastic clinician is not going to reach 5 years. So each challenge has a design answer. So if 3 children entered into the registry as MRI negative, and if the first has a 3T study reported by pediatric neurologists, the second has a routine scan with no epilepsy sequences and no second read, and the third, who had no accessible scan at all, and the field was completed from a clinic letter, and pooled together in the registry, these 3 children will be analyzed as one phenotype, which is MRI negative focal epilepsy, and any conclusion drawn from that group is going to be an artifact of our data model. So we need to replace that binary field with a value set that records whether the test was performed to an appropriate standard, performed but inadequate, indicated but unavailable, indicated but affordable, declined or not indicated. And it goes one extra field, and that is the difference between a registry that measures disease and one that measures its own infrastructure. The same logic would apply to genetic testing, neuropsychology, and surgical candidacy. And if we record only the children who are operated on, we are going to publish excellent surgical outcomes, and we will learn nothing about the health system. The registry has to measure the whole cascade: the date criteria were met, the date drug resistance was recognized, the date referral was made, the date evaluation started, the date treatment was offered, and the date definitive treatment was completed. These dates matter. The dates give intervals. Intervals give the cascade, and the cascade is what a health minister will understand. So even in a well-resourced system, the attrition can be roughly 5-1. And we do not have an equivalent figure for India. Producing that figure would itself be a very significant contribution for the registry. So let's see what actually a good collaboration will buy us. Good collaboration buys us 5 things. First, the standards. We do not need a new data language. We can map to the NINDS common data elements and the ILAE terminology. We can adopt the minimum need for comparability. We can retain the variables that matter locally: affordability, distance, and public versus private sector. Secondly, the scale, because single centers describe their own practice and cannot separate the local habit from the real pattern. So multi-center data give adequately powered subgroups for rare etiologies, rare procedures, and uncommon adverse events. Thirdly, the expertise, because tiered review means that the state conference will confirm the drug resistance, the national conference will assess the candidacy, the international conference will take only the genuinely difficult cases. So the aim will be to strengthen the local decision making, not to export children. And fourth, the trial readiness, because a governed registry can answer in days how many children carry a given genotype, how many children meet age and seizure criteria, how many children have baseline natural history data. And that can be the difference between being offered a trial and being asked to join one. Finally, the quality and policy, because the output should be confidential dashboards, not league tables, and the national evidence for referral standards, center designation, and public financing. So the design answer to the heterogeneity that exists is to stratify rather than aggregate. So every child completes a short core data set, and the individual modules switch on only when they become clinically relevant. And that core must be completable during an ordinary clinic visit. Because if you have a 300 variable form entered by a clinician who already has a full list, which will then produce a retrospective entry, missing fields, and selective enrollment of interesting cases. And that will ultimately result in site withdrawal. And the second point especially matters for funders, because coordinators, protected time, and site reimbursement are core infrastructure. Registries that fail on staffing
Hi.
Registries fail on staffing far more often than they fail on software.
I
And
think
each of these.
Dr. Biju, I think it's time up. Can you please wrap up?
So I'll just go on to the I think we're discussing this later. So the greatest risk is not failing to build a registry, because it is building one that is internationally impressive, scientifically non-comparable, which is externally controlled and clinically relevant. So the alternative would be an India-led global interoperable learning system that's going to strengthen the centers, exposes the gaps in the pathway, and measurably shortens the journey to definitive treatment for our children. So I'll stop there. Thank you. Thank you.
Thank you very much, Dr. Biju. We have a working group which are designing on some points which you have highlighted. If you don't mind going back to some slides, just to bring it to the attention of data group. Just few slides back, please. Chicken madapa. Quickly back, please. Slide back. More.
This one? Yeah.
No, before that. Before that. Back. Yeah. No, go back, please. Go back.
This one. Yeah.
No, before that. Yeah, I think, sorry, on this slide, I think we highlighted this about definition of hypoglycemic injury. I think also the referral pathway and the hidden denominator. Yesterday, Dr. Naveen Sankin also highlighted not to miss the denominator, because we need the denominator as well, even if they don't qualify. And also next slide, some good points for us to say that we don't take binary yes or no. I think that is a very valid suggestion, Dr. Biju. Next slide, please. Yeah, here like the registry answer, replace the binary when we have no clear-cut hypoglycemic evidence. How do you say hypoglycemia probable, possible? And these points can be highlighted to many of the criteria like MRI. MRI was indicated, not done, or MRI 3 Tesla suggested, or 1.5 Tesla. These points we can always take away from the binary. This for the working group which is looking into data collection.
True.
Thank you.
Thank you. Thanks, Dr. Rima. Thank you.
The next talk is by Dr. Anjana Sivagamurthy on International Pediatric Neurology, Research Consortia and Registries, how the registry ecosystem functions. Dr. Anjana Sivagamurthy, MD, MPH from Children's Hospital, Philadelphia, where she serves as a natural history regulator core lead. Over to you, Dr. Anjana.
Can you see my screen in the presenter mode?
It's visible.
Okay, perfect. Thank you so much. Hello, everyone. First of all, thank you for inviting me to speak today. It's truly a privilege to be here among leaders in pediatric neurology across India and globally as well. Definitely had a fangirl moment there when Dr. Paul was talking, having read his textbook. I'm here to share my perspectives on the landscape of US-based registries, specifically around the design and stakeholder engagements and how that is required to ensure sustainability. Just a little introduction about me. I'm a physician scientist at the Children's Hospital of Philadelphia, and I also lead the real-world evidence core within the NIH-funded Global Leukodystrophy Initiative Clinical Trial Network. And much of my work focuses on using real-world data to build regulatory grade harmonized natural history data sets for rare pediatric neurologic disorders, primarily leukodystrophies. And this data is being used to support clinical trials, regulatory decision-making, and to inform clinical care standards. And what I will be sharing today in my talk are my perspectives, having worked at the interface of between multiple stakeholders and what I've learned from it to create and sustain a registry. So what does it actually take to build a registry? People often think it is choosing the software and deciding the variables we collect. In reality, these decisions come much later. I would like to think about it as 5 essential building blocks. The very first question being the why. Why are we building this registry? Defining the purpose of the registry enables us to identify the stakeholders and their expectations early on in the design. Once the purpose and expectations of the registry is aligned, governance naturally follows, including identifying members to a steering committee with representation from stakeholder groups, determining the level of ethical committee overview that will be needed, and also establishing collaborations with groups that have shared interest across institutions both locally and internationally. Second, but a very critical element of this building block is funding. This is essential to the survival of the registry. Planning for funding sustenance should be an integral part of registry design and not an afterthought. Sustainable registries often have a diversified funding source. For example, government funding the overall infrastructure and data collection, patient foundations supporting patient engagement, industry supporting disease-specific data collection for regulatory submissions, academic investigators generating pilot data and publications to strengthen future grant applications. Next comes the scientific design and infrastructure. So defining the study criteria, the cohort, having a plan in place for patient recruitment and continued engagement over time, and identifying the minimal necessary data elements to collect. High-quality registries focus first on collecting the minimal data elements that reliably addresses the purpose of the registry, but includes infrastructure to accommodate additional data collection modules later to support deeper disease-specific study needs. Finally, data quality and stewardship, which is as important as funding when it comes to ensuring sustainability of a registry. Trust between stakeholders determines the sustainability of a registry. Especially in today's AI and machine learning world, data is gold. And questions of data ownership, privacy concern, interoperability, and alignment on data standards, not just locally, but also at the global ecosystem, responsible sharing and strategies for collaboration should all be defined a priori for continued trust and collaboration between stakeholders. This is a figure that I see as summarizing how these building blocks come together when building a registry. I like to think of the workflow in developing a registry as moving from a forest, so having a very big picture view, to a leaf where we are talking about nitty-gritty when operationalizing a registry. At the forest level, we are making big strategic decisions. There are 2 levels of strategic decisions that will need to be made at the get-go. So, and representatives from all stakeholder groups should be involved when making these strategic decisions. The first level of strategic decision is about now. What is the purpose of my registry for the next 5 years? Who are going to be my stakeholders, and what is my governance plan? And most importantly, funding. Do I have funding to set up the registry today and sustain that registry for the next 5 years? And the second level of strategic decision, which has to happen today as well, is around the near term. In addition to the primary purpose of the registry, how can I expand the purpose of this registry in the subsequent 5 years? Who will be my stakeholders? What changes to governance plan should I anticipate? And who should I start to engage with today? And what kind of evidence will I need to generate to reliably ensure that I'm able to secure funding for the subsequent 5 years? As we move towards the leaf, the workflow becomes increasingly operational. Data set design involves establishing collaborations across institutions and patient advocates, defining the cohort of interest, identifying the data elements we want to capture, and this involves researchers, clinicians, patient advocates, and maybe some of the other stakeholders too, depending on the purpose of the registry. We then engage with database analysts to build the infrastructure to support data collection. Upon launching the data set, we enroll patients to collect data. Most importantly, have a plan in place to maintain continued engagement with families and patient advocates for continued longitudinal data collection. And then it is essential that we stay engaged with regulators from get-go to ensure agreement on the rigor and quality of data, to inform regulatory decision-making, and inform the need for policy changes that we may need to accelerate scientific advancements in the space. Finally, generating high-quality evidence to address stakeholder needs and to keep them invested is very critical. Registries exist and thrive because stakeholders see value in it. Payers contribute funding interest and get outcomes data that helps advance research. Regulators provide oversight and co-design and get real-world evidence for guidance generation, and ultimately bringing safe and efficacious therapies to patients. Clinicians contribute expertise and researchers contribute scientific rigor, and together get data that inform standards of clinical care, publications, collaborations, data to secure additional funding and recognition. Industry partners contribute funding and infrastructure and get natural history data, trial patients, clinical trial design input, and therapeutic biomarkers. Patient advocacy organizations contribute outreach and funding and gain an amplified voice in this space. Patients and families enroll and contribute data to access safer, more effective therapies and a better standard of clinical care. What is important is that every stakeholder both gives something and gains something. When one group stops seeing value, their engagement declines. For a successful registry, it is critical to balance the stakeholder interests over time and as the registry evolves. What do we need to ensure this balance? I put this slide as a summary of the previous slides about keeping stakeholders engaged. First, defining the purpose and the use case of the registry and ensuring stakeholder groups are aligned on that. Second, incorporating a tiered data collection similar to what Dr. Hamid mentioned. Having a plan having a mandatory core data set, but also having a plan in place to accommodate additional data collection modules as needed. Having a steering committee from day one to ensure that all stakeholders have a say in the decision-making and their needs are met. Pre-negotiated data agreements on data ownership, strategies for collaboration, publications, and embargo terms settled much before data collection starts. And finally, patient's voice embedded within the registry design and not at the consent. Next, I'd like to share some lessons on sustaining a registry that I've learned from my work within the GLIA CTN. First, diversifying funding. Having a combination of public and private funding sources is optimal. A consortium like infrastructure can be helpful, particularly when we want to bring together multiple institutions under one regulatory umbrella and to ensure consistency and interoperability between institutions when contributing data. Patient advocacy committee committees should be incorporated to share priorities and not just consent. Early regulatory validation of any one use case can be helpful. In our case, we developed FDA's acceptance of natural history cohort for metachromatic leukodystrophy that was used and accepted for use as a non-concurrent control cohort, proved as a use case model that helped attract funders and partners to fund other disorders as well. Designing the registry to be repurposed to answer multiple questions. The same data set to answer natural history, trial readiness, biomarker questions for every funder, and not just as a single-use asset. Across the medical field, there is much less representation of Southeast Asia in the global stage, particularly with registries. And closing that gap starts with knowledge sharing and not just infrastructure building. This expansion only works if it's built on shared technical grounds. So incorporating capability to align on international data standards like CDASH for regulatory submissions, making sure data dictionaries adhere to standards such as NOMID, CT, LOINC, or using common terminologies or data elements. This will help, this kind of alignment will help integration into the global ecosystem. India has extraordinary strengths, and to name a few: large patient numbers, exceptional clinical expertise, significant genetic diversity, increased research capacity. The question isn't whether India can contribute to the global ecosystem. The question is what role India plays in the global registry ecosystem. Data becomes exponentially more valuable when it can be integrated into the global ecosystem. That's where organizations like the AOCN can make an enormous impact. not only by collecting data, but also harmonizing data across institutions. By increasing regulatory literacy, as well as literacy on data standards among members, AOCN can generate data that can support global submissions, not just publications. Through Child Neurocon and quarterly newsletters, AOCN can expand collaborations locally and internationally, keeping patients and stakeholders engaged as well as incentivized, and attract drug developers globally to bring diagnostics and therapeutic advancements to our patient population. In closing, if there is anything you should take away from this talk, I think it would be that a successful registry requires a clearly defined purpose, stakeholder alignment on purpose, clarity on incentives, and a diversified funding portfolio. Thank you.
Thank you, Dr. Anjana. I think most of the points what you have covered has been addressed. Hopefully there is a lot more to take. And once again, thank you from all of us. 2 o'clock in the morning, you have stayed awake for us. Thank you.
Thank you.
Thank you. Please give her a round of applause. It's 2 a.m. in Philadelphia, I guess.
Thank you. It's been a pleasure. Thank you.
We have the next talk by Dr. Amin Shukla. She'll be talking on research funding body, ICMR, DST International, grant mechanisms available for consortia. Dr. Amin Shukla, she's a pediatrician and scientist at the Indian Council of Medical Research, where she coordinates the ICMR National Registry for Rare and Other Inherited Disorders. Over to you, Dr. Amlin.
Yeah, first of all, very good morning to each one of this eminent gathering. And I thank AOCN for considering me fit for this conference and letting me present here. The purpose of talk is, one of this is mentioned here. The second is challenges and opportunities in the ICMR registry, as you talked about just now. First of all, I congratulate AOCN for bringing out this neonatal hypoglycemia and brain injury registry, which, you know, it is very important that each of the pediatric neurologists comes closer to research and contributes to early child development and developmentally supportive care, early interventions as much as possible, and provide their contributions to research. And you're already, I congratulate each one of you to contribute to this country's future by securing neurodevelopment of the children that you're already seeing. But opportunity is vast here. You can expand your, area to a lot more and unexplored and new areas of public health research. So here I am presenting on behalf of ICMR and what ICMR has to offer in terms of funding opportunities, what pediatric neurologists can have, what is ICMR's priorities. I'll throw light on some of these issues. So ICMR is one of the oldest research body in the whole world, being established in 1911. And we have gone through ages and now evolving as the time goes, learning from each and every piece of research that has been funded and coordinated by ICMR. So what we have learned over these years is coming as close as possible to the public health issues of national interest. It's very important because it's not mentioned here, but the gap between evidence and the delivery of the evidence-based interventions is quite high. And recent studies and our experience has shown that covering that last mile gap between evidence and delivery of the interventions is very important. So this is the latest focus area of ICMR as of now. So we are trying to align ourselves to national interests, designing research opportunities to cater to the problems that lead to filling up of this gap between the evidence and delivery. ICMR has mainly two wings, intramural research wing and extramural research wing, and there is a separate program called National Health Research Priorities Program. So this is the extramural research wing that will be relevant for the people who are present here, and also NHRP, that we call in short for National Health Research Priority Program. So that will be relevant for people here. So recently we have divided ourselves into these four domains: discovery research, development research, delivery research, and descriptive research. So in about 2022, we reflected on what kind of research on priority we have been doing over the years. So it came out that we have been mostly doing descriptive research, like finding the burden of diseases, finding pathways, and so on. So that's how we came to this conclusion that the delivery research has to be now the focus. So delivery research, it focuses on essentially this covering up of the gap between the evidence and the intervention. Of course, discovery and development are equally important. Discovery pertains to finding out new molecules, new techniques, new pathways, new algorithms, everything that is new. And development research is pertaining to the validation of those new methods into evidence-based interventions. So whatever grants that come across support all these delivery research, all these research domains, but the of interest in particular to ICMR at present are development, discovery, and delivery research. So you would also find this on ICMR page. EPMS website is there, where you will find the ICMR research priorities. These 12 are mentioned in the left side, are National Health Research Priority Program priorities. So through National Health Research Priorities Program, ICMR develops ideas and regularly posts expressions of interest on its website that I'll show you shortly. So these are the main areas, and about 30 national health research priority projects are running as of now. So whenever an expression of interest a call for proposals is published on the website, each and every Indian who is also a researcher is eligible to apply for this, of course, based on the relevance. In all other calls on the table that is on the right-hand side, you can also see there are many childhood and neurodevelopment and neurology related issues, like early child development that you, I don't know if I can use this. Okay. Early child development is mentioned here. Okay, this is a priority for ICMR. Okay, thank you. Then, of course, all other overarching areas are there that neurology also becomes part of. Okay, thank you. Okay, fine. Yeah, so just talking about a bit about the extramural research program. So these are the special, these are common type of grants that ICMR has to offer. Small grants, intermediate grants, Center for Advanced Research. The fourth one is mentioned as First in the World Challenge, but apart from the First in the World Challenge, there are numerous other kind of grants also. So First in the World Challenge pertains to, yeah, it was inspired by the Chandrayaan-3 landing on the South Pole of the Moon. So making India the first country to do so. So inspired by that the idea came to our Director General that we will now grant the first in the world research ideas, starting from proof of concept to prototype development and then validation and final product. So there are different stages. So any of you, if have such a first in the world idea, you can apply for this grant. Keep looking on the ICMR EPMS webpage. Then apart from these grants, there are MDMS grants. There are for the MD thesis. If okay, I'm already short of time, so I'll move on. Yeah. So these are the just the up to how much it can be funded. Up to 2 crores is the small grant, 2 to 8 crores is the intermediate, up to 15 crores centers for advanced research. And be mindful that one of this Center for Advanced Research grant is still on. You can find it on ICMR EPMS webpage. I'll just skip this. So this is the ICMR website. You can find about the expressions of interest under the call for proposals under grants and funding. So this is where you can find it. And this is the ICMR EPMS webpage where you can find about the small grants, the intermediate grants, and the centers for advanced research. So one of the CAR, Center for Advanced Research, CAR that we call in general. So you can find that. Please go and find and submit before the deadline. Yeah. So this is how the proposal review process happens. It is based on rationale, the possible impact, novelty, methodology, implementation strategy that the all proposals are marked. And these are the tips for writing a good grant proposal. So understanding the guidelines and objectives. So these are the headings in which you'll have to enter your proposal, and there are some takeaways from our experiences of reviewing these grant proposals that we find it important to tell about. That, for example, the title and summary should be very clear. And as clinicians and researchers, you already know that the title should be properly reflective of your research. Then the problem statement and rationale should be very well aligned to all the literature review that you have done. It should be having novelty, and proper rationale should be existing. Yeah. Okay, the next part is about the registry. So I was also asked to talk about this, and if I'm permitted, I can continue, sir. Okay, so we are having this National Registry for Rare and Other Inherited Disorders. I'm coordinating that registry as of now. It's initiated in 2019. And now we have about 22,000 patients of rare diseases enrolled in this registry. The follow-ups have initiated in the previous year only, so you are seeing the numbers low. So it was like initiated in a phase-wise manner. Initially, we were exploring the opportunities of getting established a national registry. And step by step, we developed the follow-up, the adding of other diseases, alignment with the national rare disease policy also. So broad disorder groups at present in the registry are storage disorders, inborn errors of metabolism, hematological disorders, skeletal dysplasias, primary immunodeficiencies, neuromuscular disorders, renal disorders, endocrine disorders have been added more recently. And these are the 23 centers in the map of the country that you can see that are collaborating with the registry. The purpose of the registry was to develop a database of rare disease patients in India. Broader purpose was also to find the burden of each of the rare disorders so that it can be fed to the policy, the national policy for rare diseases, to prioritize the problems. So, but I will be talking about that, the challenges were there, etc. So, for the registry, how it initiated, core committee came together with initiation of ICMR. Initially, Dr. Rita Rasaili was there in 2019 who actually initiated the registry. I joined later in 2022. So initial discussion of how to include the diseases, how to involve the diseases. So the diseases that were amenable to treatment, that had some diagnostic methods available and had some sort of cure or effective treatment that could help patients live a better life were initially included, and that were relatively commoner were included in the registry. And later on, now we are, as the rare disease policy of India permits, we are adding new diseases aligned to the national rare disease policy. The reason for this is that the government, it subsidizes and funds the diseases that are included as a part of national rare disease policy. So it does make sense to know more about those diseases that are already funded by the national rare disease policy. So over the time, letters of intent were invited. I think we received over 50 letters of intent. Among them, 23 centers were selected. So the selection criteria for the centers was availability of pediatric expertise in rare diseases, and availability of diagnostic facilities. Then protocol, consent forms, etc. were developed. Then the case record forms were developed. And if I talk about the challenges, so we did find challenges of how to select the diseases, because more than 8,000 rare diseases are existing, and how to be fair to all the patients of those who are suffering from rare diseases. So to begin with, we decided on the commoner and amenable to treatment disorders only. Then heterogeneity of the diseases was another challenge. So we have a core form, like the previous speaker also told. So we have a core disease submission form for each patient. And then based on the characteristics of different disorders, we have different forms for different disorders in which the data can be entered. The data is centrally managed through the electronic data entry system, with the server being at ICMR, and the front end for data entry being available in a password protected manner with the sites. Then other challenges were like case duplications were there, how to ensure that the same patient who is going to different centers does not end up being entered in the registry twice or thrice. So we had to make some provisions for that, like having combinations of name and phone number, then Aadhaar card, but then Aadhaar card is not mandatory. I mean, we cannot force anyone to share their Aadhaar information. So later on, we had to make it non-mandatory, and we are managing well with the name and phone number combination to avoid duplication. Then a lot of training awareness, because this rare disease data entry itself is a complex thing. So the data entry personnel have to be really trained and retrained to enter that data. And data quality assurance, we have made a 4-step mechanism for that. So first, validation checks are there in the form itself. Then the site PI has to check the data entered in the form every week. Then there are nodal centers made, and a separate nodal center dashboard we have, where each and every form is checked, and whether the QC pass or QC fail is displayed there, and the form is sent back to the centers to be refilled. Okay.
Thank you. I think we need to.
Should end here. Okay. So fine. I think I've given some accord of whatever experience we have had in this short time. It is very difficult to tell about all of the experience. We are also going to, publish that experience that we have had. So we have already submitted in the Orphanet. I think it will be published, and whenever it is there, it will be open to read for all. Yeah. So I think I can end. Thank you.
Thank you very much, Dr. Amlin. I think the next session is more about whatever discussion have happened in the last 24 hours. And I hope you will be part of it and contribute to this. Thank you.
Thank you, sir.
Thanks to the speakers and the moderators. So we have finally come to the final session where it is time to draw a consensus. So for this, I would like to invite Dr. Prashant sir, Dr. Murali sir to come on to the dais and moderate the session. And here we'll be discussing the recommendations, only the summaries and the recommendations which have been made by the expert working group as well. And each representative will only have 5 minutes. Kindly stick to the time. Thank you.
So, good afternoon. I think all of you are aware of the expert working group deliberations, which we have been, part of for the last few days. So again, to sort of, just to give clarity to the larger group, the intent of this exercise was basically to come out with a sort of, AOCN's position statement on how to fill the critical evidence gaps in child neurology. What should be our roadmap for the next 3 years? We have formulated 6 working groups. We have come out with 6 interdependent themes. So each working group was requested to work on a specific theme and come out with a structured document which can be later on articulated into AOCN's position statement with 6 different chapters in it. So we would welcome one representative from each expert working group to come on to the dais and provide a sort of brief account of their discussions for 3 to 5 minutes. And then if there are any questions or suggestions from the larger group which can be taken up. So may I request the expert working group 1, who is presenting from expert group number 1? Anybody?
I will be presenting. Can you
I
just
think Dr. Shefali ma'am wanted to join
yeah,
online, and
I'm already online. I'm
the
already
madam is
online.
online. Yeah.
Yeah,
So I welcome Dr. Shefali Gulati ma'am from expert group number 1 to sort of outline what should be the AOCN's research priorities in the next 3 years. If AOCN can fund 3 research priority areas, what should be these priority areas, and and provide sort of a reasoning why they are proposing these 3 priorities. Over to you, ma'am.
Yeah, I'll just take a minute only because I just want to share what the group had felt, and then we will. Can you hear me? Can you hear me? Can you hear me?
Yeah, ma'am, we can hear you. Please
Yeah,
proceed,
sure,
ma'am.
sure. I'm just saying, I'll just take a minute. I mean, there's a document, you can share that document on screen. Otherwise, we can just, that's for debate basically from the entire group, that DEs are one thing which we see very often and we need to address. So, and there's a lot of precision medicine coming in that area. So the DE would be one area which the group felt. Rest will be, I mean, can have inputs from the rest. Second was autoimmune, and autoimmune, yes, we did collate data. Dr. Udani and Vishal had done. So I think it should be there. It needs a lot of there's so many things coming up in that area. And third was neurometabolic, which gets missed out. So the group had felt these three as areas, one being DAE, second autoimmune, and third would be the neurometabolic proposed. So I think the reasoning has been given in the document, yes, but basically it's just because we understand the magnitude and the precision medicine coming up, and we understand we need to have systematic thing. So these three are there, and I would anybody wants to suggest now, or it can be put in the group or can be sent so that
Thank you, ma'am.
we overall
I think
these
these are
can
three
discuss.
major
Prashant,
areas
yeah.
where we need to work. I would, however, would want, ma'am, if you can further specify if in neurometabolic what exactly you would like to propose, so that maybe we can have further consensus on it.
There was a
Otherwise,
Word document which was to be shared. I mean, they're not sharing. It's okay. Then I think we'll have to. But point is, first these three areas main, if they are proposed, I mean, if they are okay, then uske baad we can think about the, the particular focus, because otherwise they will have a research portion to be focused on, right? So, I mean, we'll have to see which are treatable ones only and responsive ones. Maybe, we can talk about vitamin responsive epilepsies, and that can be focused on, or
I think
something
that would
which,
be a great idea, ma'am, that we start
yeah.
with these treatable neurometabolic disorders
Yeah.
and go and build upon it.
Yeah. You
Thank
can
you.
take
Thank you, ma'am.
discussion.
So
Thank
do
you.
we have any comment from the audience? Anything that is coming up in your mind that you want to suggest beyond these three, or you want to specify something within these three broad groups?
This one here would be the neurometabolic disorders. Depending on the center where you are working, there would be a geneticist or a metabolic specialist who would be predominantly handling it, and the neurologist might have a little role, and they may not be seeing them much as well. So in that way, I think you might get a very skewed information if only pediatric neurologists are looking at this data. That could be one of the caveat.
Lokesh, we can do one thing now. We can
So I think so,
in different
but that
sites
would
we
be a
can have
good start
they can
on
be
a
partners. They can
clinical
be
front.
partners. They
Maybe
can
the
be partners.
neurologist leads it, but in that group, we definitely have other stakeholders be there.
If you are
We
doing
agree.
that way, then we'll have a more comprehensive data. But if only pediatric neurologist gets involved, we might get a very, very skewed information.
Lokesh will have to partner with our other partners. We
Yes,
cannot be
please.
focused. So we'll have to have them as a team. Yeah.
No, that is a very good idea, and a big proportion do develop stroke, and we don't have any consensus on that. So okay, we can think of it. We can think on it.
What was the topic, Prashant? I couldn't hear.
What is the tangible outcome? Then based on that, we can take it.
So we can close this discussion now. So we have these three broad areas to go with, and a friend of us has suggested to include stroke as well. So we'll look into it, and we'll want you all to actually think over it, and maybe you can give your suggestions. So we can move to the next working group.
Kindly request all the groups to keep it very succinct. 5 minutes is the time allocated to each group. So probably quickly, maybe initial 3 minutes, you can take us through broadly and need not go into the nuances. And then 2 minutes group can have their inputs, please. Can you display EWG2? Yeah.
Okay, so as per the expert working group 2 discussions regarding the AOC and data quality charter, the theme we have discussed was how to maintain the objective data quality standards and to ensure the compliance of the operational framework. Second is ethical committee approval, compliance, and the consent management. Third is the data ownership and the entitlements and the change management. The first was objective data quality standards maintenance and the operational framework compliance. So the 6 dimensions of the data quality, which is applicable to NHBI registry. One is accuracy, second is completeness, third is consistency, fourth is timeliness, fifth is validity, and sixth is provenance. So complete line means more than 98% of the critical data variables or the benchmarks we are going to keep should be completed. Timeliness, the entry of the data, and completeness within the 14 days of the first enrollment of the patient. Accuracy, consistency, reliability, and the follow-up will be monitored. To ensure the compliance, we are going to decide the centers mainly as a tier-based approach, like tier 1, tier 2, tier 3, depending upon the quality of the data they are giving and the quantity of data they are providing. Second, we are going to set a minimum essential data set to rely the data is reliable to be enrolled. Third, the AOCN will adopt a firm but maintaining approach to maintain the quality and the center's excellence. Fourth, clearly laid down data governance rules and the reconciliation process. There should be the tool level and the process level to validate them. And fifth is the ongoing data quality monitoring and the feedback sent by the center. Ethical approval, compliance, and the consent management. So there will be strict ethical committee approval is required as per their clearly detailed outlined policy. We are going to follow ICMR 2017 and CDSCO guidelines. AOCN Secretariat will mentor and facilitate the small centers, and there will be the standardized consent forms in the local language and also the dynamic consent. The most important, data ownership and the entitlements. This is the practical problem we are going to face. So the participating centers will own their data. AOCN will be has a custody of the pool data. Pool data usage will be governed by a clear policy that is like how much volume and the scope of the data is contributed by each center, the quality of the data they have provided, the intellectual contribution to the manuscript work, and the other relevant aspect, the most practical problem again, child moving across the practitioner to avoid the data duplication. Change management, practitioner leaving the hospital who was actually helping us to give the data. If the center is entering, new centers are actually entering into the registry or the old centers are leaving them, and there any change in the diagnosis and the treatment guidelines.
So any questions from the audience to expert working group 2 or any other suggestions? Hope all the dimensionalities have been covered by this expert working group. So any constructive insights are welcome.
If there is a center with 4 consultants and the PI is this one, and there is 50 centers contributing to this, as there's a paper coming out. So the authorship in that situation, how does it go? How does it work?
So usually, sir, we can define certain quantum of data benchmarks. Another, for example, there is a center which is newly onboarded, just started contributing data, have not even contributed 5-10 patients data, for example. So they may not be eligible to get into the authorship. So we'll define certain benchmark, okay. Only centers after entering, let us say 20 or 30 high quality records will become eligible for the joint authorship. So definitely when we are using the pool data and they are crossing that set benchmark, so all the PIs of those centers would be eligible to be co-author in any publication coming out of the pool data. And the authorship sort of order or who will be holding the first authorship and other things, again in the governance framework we can clearly outline all those criteria. So anybody who wants to sort of analyze the pool data, they can write to the executive steering committee, and committee on the merit of each proposition can take a decision, and everything would be objectively documented and very transparently managed. Any grievance redressals also, there will be a grievance redressal mechanism built into the governance framework. So any grievance redressal again can be communicated to the committee, and committee can again objectively verifying all the facts, can provide solutions to all the grievances raised. So all these things will be built into the governance framework.
Yeah, another aspect might be if maybe Dr. Sandeep Patil wants to write on drug refractory epilepsy and the surgical outcomes in this group. He wants to volunteer and said, can I have this data? How does it work in that situation?
So usually, sir, how other sort of consortiums manage these things is basically any research idea, the idea bank. So there will be a mechanism where you can register your idea, and you will be probably having a certain time period sort of, where you will be the owner of that particular idea. And if you are proceeding with the protocol writing, analysis and writing, then you will be leading that particular manuscript writing effort. And then we'll again be sending an open notification to everybody who would like to be part of this particular manuscript exercise, and anybody expressing interest can assume the role of co-authors in that particular paper. Depending on the contribution they are providing to that particular manuscript exercise, the authorship order, everything can be clearly outlined in the beginning itself, not later, not after the completion of work, but before the undertaking of the work itself. And then with the mutual consensus, so we can go ahead and start sort of producing scientific outputs from this database.
Dr. Sandeep, I would just like to add a few things here. So see, whatever we have, Konika has presented, we have actually defined most of it. So it will be everything would be appropriately documented. Now, when these issues will come in, so the person who is requesting, they have to present a proper validated protocol, and then must have contributed to the data collection. So it's not that only ideas, giving out ideas would be actually taken up, but you have to be an active contributor, and then we'll define that a certain amount of contribution has gone in before we are going to take up that proposal. And then we have a steering committee, and then another scientific committee, which is going to actually look at the nitty-gritties. So it will be, it is not a single time, it is an evolving thing. So we keep on revising things as and when some new complication which has not got addressed somehow. So that will be there. So what was your?
Yeah, no, I was just asking, is there a provision? Suppose we come up with research idea and we are a collaborator and ask for that research idea to be study in detail. So can we go back to the patient and take a details? Like in our form, we have some preliminary things, right? So if we want to go into detail, suppose in epilepsy type or MRI type, so can we go back and reach out to the participant as a researcher, researcher from the group, and take a detailed data from them?
Okay,
Is it possible?
so see, that is a very good point, Dr. Sandeep. Many of us would want some more extensive data sets to be captured so that we can come up with some particular objective. So what we are actually envisaging is that there is a core study which is there, and it is already has nested studies in it. So if you already have an idea which you think is not getting covered, so you can straight away at the beginning itself, you can let us know. So we will try to incorporate that additional data sets that maybe you would want us to do that. But what we are trying to do is probably we will have all that information that you wanted to suggest, because we want a lot of people to be there on board. So we don't have an eligibility criteria that you have to meet everything to be on board. So we have a core eligibility criteria that you can just come and join us in that study, but you want to contribute more, then you are welcome to join those nested studies. One of them would be on neuroimaging, one of them would be definitely on a DRE, whether what is the outcome of epilepsy surgery maybe in this particular subset. So all these things we are trying to incorporate already. So if you say your center is equipped enough to do a proper neuropsychiatric evaluation, so you are running a psychometric test, you have a system in place, so you are welcome to join that group as well. You want to join for DRE, you want to join for maybe others like SLD or other neurodevelopmental disorders you want to look at. So this is all inbuilt. But if a center is not contributing to that specific data, so that center will not have any access to this information.
Yeah, I agree. But I wanted that when we are taking the consent from the patients, like initially when we are putting the data, we can put that point that if any other information is required, can we contact you? So we can take the consent.
Naturally, so that would be there in the consent. So see, registry, though it might sound like a cross-sectional assessment only, but we will have this in their loop that there would be some sort of a prospective assessment. The moment you say that you are going to be prospective, multiple times the patient will actually, the data has to be revised or some new information that has come up. So we are thinking of running this registry for maybe years. So we would want to know that at 2 years of age, you have documented these complications. Maybe at 5 years, the child actually grew out of some certain things or had developed something new. So that is the purpose of having this. So we will definitely have.
Yeah. So that is where we have mentioned, it is going to be a dynamic consent management system which will be inbuilt into the registry. There might be need to obtain consent on multiple occasions from a single participant. Can we request a representative of expert working group 3?
So
the expert working group 3, yeah, please, Doctor. Yeah.
Just a comment I wanted to make. If we can try incorporating ABDM also within the framework. I think I'm not aware if it's already in the plan.
Yes, sir. I think one of the suggestion given was that if ABHA number can be incorporated as one of the identifier, so that that provision also will try to make it in the registry. Very
not
valid.
compulsory, but it can be optional.
That can be an add-on, identifier variable, which is easy to track. So expert working group 3 is talking about the NHBI registry specific. So what are the opportunities this registry is going to offer to AOCN? And what are the anticipated challenges and what are the mitigation measures we need to put in place?
I'll start speaking. So I'll start speaking in the time they're loading this. So 2 questions were given to a group to answer. One was, what are the 3 most impactful outputs the NHBA registry can produce in the next 3 years? The first, the topmost which the group agreed upon was to establish the burden of the disorder in our part of the world, the incidence, prevalence, and the impact and morbidity of NHBI. The second one was to try to answer some unexplained questions, like identify certain subgroups where there is a paucity of an explanation for the problem. For example, children with who develop hypoglycemia, who are apparently low risk and were unmonitored, and thereby in the long term to establish protocols for monitoring all newborns probably for hypoglycemia. And to find out why Indian children are much more prone to develop hypoglycemia when compared to the other children in other parts of the world. For example, for coexistent sepsis or intrauterine growth retardation contributing to their vulnerability to brain injury. So these are the 3 things which the group decided as the probable impactful outputs this registry would produce in the next 3 years. Then coming to the second question, what are the 5 ways this registry could fail and what would we do in the first 12 months to prevent each? The topmost among the list which the group prioritized was initiative from the pediatric neurologist, and the second one was cumbersome interface, that is the registry should be made user-friendly. And regarding the initiative, most of the members in our group felt that there should be data entry operators, because anyway there are going to be a lot of fields and free text as discussed yesterday in the discussion. So at least on a zonal basis, if the association could provide data entry operators to help with the data entry, that would help in sustaining this initiative. And of course, the third one would be funding. And the fourth thing which the group agreed upon was the registry has to be a priority, just like as it is now, even if office bearers are going to change. So this has to be a long-term initiative. For that, it must be put in the charter or something like that, so that this gets carried over in the next years to come as well. So these were the 4 things which the group felt were the challenges or the points where this registry could fail. Thank you.
So thank you so much. Any questions, any suggestions from the audience? I think some of the challenges which registry can encounter, including making the interface user friendly and also providing data entry support through secretariat. These things were already deliberated upon, and I think the mechanisms are being explored to sort of set up a support system in place.
Currently, we probably are looking at 2 data entry operators across India, where through the AOC, and maybe we'll have to check out around 3 lakhs per year to support those data entry operators. As already mentioned in one of the talks, the reason for failure is supporting the data entry operators, and that could be one of the major reasons to fail. So we need to have those things. So initially 2 people will start off, and then based on the requirements, whether we can upgrade it to more 3 or 4, we are going to look into, because we need to have a sustained support for years together for that salaries. So we're looking at all those options.
So, sorry, I got
will
lost
initially
there.
propose is we'll have 2 people who will be guiding you. So they will not be always available with you to enter the data. So this understanding also has to be in, because I understand that this is what is most important thing for the feasibility to be there. But there would be financial constraints. So because the salary and packaging, everything has to be seen. So we are envisaging that we'll have 2 people, but they will be actually trying to train someone at your place who can appropriately enter. But it will be the center PI's responsibility of that center to see that valid and robust data entry is happening. So at some point of time or weekly, you need to be there. So we'll also have some checks, maybe that weekly you have to enter some data. So if persistently we are not getting any data getting entered from that place, we'll send you a reminder, but we might make up some sort of a protocol that after certain reminders, if we don't get a response, then we'll have to stop that such center as well. For your first question that you have answered, your group, so let me also put it in this way that this will have limitations. Our registry is going to be having some limitations, at least at the beginning, because we are not going to do it in a prospective manner. It is not that we are following a birth cohort, so it might not give you these answers that you are seeking in the first 3 years. If we feel that we have the neonatology team together, or we have some access to their data where they already have hypoglycemia, then maybe only we'll be able to. So at present, we will be looking at more the low-lying fruits, so that we get some answers, and then we will expand depending on. So we would be trying to look at what proportion develops drug refractory epilepsy. So what is the spectrum of neurodevelopmental disorders these people have? And are there additional risk factors? What type of care, which will be some sort of a verbal autopsy only. So we will not have, it will have a recall bias. So this is what we are actually thinking that we'll be able to get. And later on, maybe we can definitely have that. That would be the best thing to actually get to the risk factors and remove them.
Dr. Prashant, just a small comment. In the beginning, when we are starting this registry, maybe in the Google form, you can ask whether the center has 1 or 2 persons who are dedicated to do that registry entry. Because if we are not going to provide a data entry operator to each center, the center might be a very high flowing center, but if they are not able to enter the data per se, it will dilute over a period of the time. So my request and a suggestion is that please, while you're enrolling the centers, it's not the willingness alone, but also the ability to provide a dedicated manpower for that particular project itself. Otherwise, it will get diluted over a period of the time. And as the funding agencies, we start approaching, if ICMR DBT on a later date is providing the funding, each center can be provided manpower.
So if you even, please go ahead.
The standalone centers like ours, where we don't have anybody to help, it is only our staff, which might not be that much clinically trained. At least once in 15 days, or when you're starting it, You can just have some training module for them, just online training, and train them that we as a PI, we need to do it. But if it comes from there, it also it becomes easy for us, at least once in a month or once in 15 days, because it is, we can understand if 50 centers are there, you can't provide 50 personnel to each center. But if you have a training of those people, then it becomes easy.
Now, that has been inculcated as a part of the program, that there will be combined hand-holding exercise. I think for individual centers, providing this one will be difficult. So somebody who's already existent in the system, incentivizing their work by a little bit extra money and say, okay, you're entering this data, we are going to give you 5,000 extra or something like that, would be a better provision, rather than trying to hire somebody extra for this work is not going to be possible anywhere in the world. So we currently, just to get 3 lakhs per year for only 2 people, which will be paying 12,000 or so, or 12,500 per month. That is what it's going to be work out to chalk out 3 lakhs per month for 2 people for the country. So that we are trying to increase it to maybe 5 lakhs. We'll have to ask the AOCN body to say whether they can chalk out 5 lakhs every year for next 5 years. So if that commitment comes, they maybe will have 3 operators.
Workers, they for each form they get some money.
Yeah.
So instead of giving 5,000, 4,000, even 100 rupees, 50 rupees filling each form for the staff, that is class 4 staff, I think that also would suffice and will save the money.
Yeah, we'll look at different ideas, whatever this one will work. But currently, at least we'll have to have standards, somebody, 2 people who can anytime, okay, this person can be addressed and this person is responsible for doing this work. So they will take on that job for initial troubleshooting.
So two of the suggestions our group had was, one, to decrease the number of free texts in the registry interface. And the second one is to have the option of opt out of if a center doesn't have the capability of hiring personnel or providing for personnel involved in data entry. Probably if they can opt out of this, probably only dedicated earmarked practitioners in the city or zone would be a participant of the registry, or everyone has to be involved in this, was the query which they had.
No, sir, I think participation is voluntary.
We are going to show the expression of interest form now. So you'll have to fill it up and send, and then we'll take it up.
So we will have a eligibility criteria. So only willingness, as was pointed out, will not do. So you have to have that ability to at least enter those core data. So before opting out, you will be able to know that whether you will be able to get in or not. And in case later on you decided that it is always, it's voluntary only, you can always do that. So, but I just wanted to say that this is a serious thing that we are going to go on. So we have to take this with seriousness, that okay, if I want to get in, then let me be serious that at least 1 entry per week is going to be done in a very robust manner. And if we see, actually it is not a very big job. So it is just that we have to incorporate the thing in us. So if we do that, maybe we'll be able to actually go and do that. And the ongoing training will definitely happen from us. So if we see that a particular center is not providing, or there is always an issue with that, so we'll go back to them. We'll try to train that person. But the center's PI will have the responsibility. So it will be difficult for us to identify staff and pay individually. We would like to go through the PI.
So one of the important mechanism we're not exploring, we have the technical capability. If the center can take, for example, if the core data set is comprising of 4 or 5 page CRF, if the center can hand fill it, and if we can send a scanned copy to the data secretariat, and data secretariat will have the capability to upload and automatically extract the data also, that kind of functionality is available in the system. So that can also be explored. I think, like sir said, multiple options would be explored, and what kind of support the infrastructure can be established to support the centers.
But whenever you're planning an incentive, if a PI is employed in an institute, the money should go to the institute, not to the PI directly. This should be clarified at the outset itself, so that there are no conflicts that are happening.
Sure. Thank you.
So can we request expert group number 4 to...
From expert group 4, we have the responsibility for the stakeholder map. As a pediatric neurologist, I am in stakeholder group. We should be the first one, the pediatric neurologist. Other stakeholder may be obstetricians, radiologist or neuroradiologist, and ophthalmologist, rehab specialist, and some primary care like ASA worker, parents and family group, some government organization like ICMR, UNICEF, or our AOCN, AOPN, IAP, and maybe the endocrinologist and metabolic physician, and also the geneticist. So second, we have already discussed that why this matters now to AOCN. From last day, we all know the burden is ideal and under recognized. So we have the opportunity to reduce a major.
We'll not go into the theory part of it. We'll just go to the tasks.
Second one is the science and technology have advanced. Practice variation still exists, and the window of opportunity. And AOCN has the unique strength to brings together experts across neonatology, neurology, endocrinology, radiology, genetics, and rehab to stronger together to build a national movement for better outcome. And what do you already know that I've already discussed also, that the neonatal hypoglycemia is common, associated with later neurodevelopmental difficulties, severe or prolonged hypoglycemia.
Dr. Pradeep will focus on the
three priority action for AOCN. The priority action should be the standardized early detection and rapid management, build capacity for etiology, imaging, and neuro prognosis, and third one is the ensure continuous care and developmental support. Three likely fault line, that is the focus of care. There is the balancing acute survival and immediate treatment needs with long-term brain protection and developmental outcomes. Second one may be the glucose threshold and treatment targets. The different views on what glucose level is harmful and safe and what target we should aim for. And third one is the variability in resource and practice. There is the balancing ideal evidence-based care with real-world resource limitation and feasibility. That was the most important question, what I think this group will need from the other 5 groups.
So, Doctor, I think our kind request, sort of again a question to the larger group also. If we want to sort of list out 3 priority stakeholders which AOCN would like to engage with in the next 3 years, and what terms we would like to engage with them, and what kind of collective good this particular engagement is going to bring to the table. That is what this group was supposed to come out with. I think if we can help the group in probably articulating that, I think it would be great.
Okay, sir.
Thank you so much.
Okay.
So please be in.
Prevention, training, the prevention, training, all those things will come there. A neurologist or pediatrician, whomever we say, and of course, parents group. But we'll need constant backup of ICMR and all those things. So I think these are 3 key holders for long term.
There was one thing that we had discussed, but I don't think it was stressed, that we should insist on early feeding. Across India, that message should go through, that early feeding is the first preventive thing. If that message doesn't go through, I mean, the registry will go on side by side, but I think this message should reach the country right across India. Early feeding.
So just one more thing, like integration of government machinery, like Dr. Parikh was telling that every protocol is there in a government, but we are failing to implement that. So if we can collaborate them somehow, like how to cooperate and
So,
and, yeah.
so it is again a valid suggestion. So this is why. So you have to make AOCN important so that someone listens to it. So that is what we are trying
We
to
can
do.
at least approach,
So,
right?
so,
As
so
an
that is so
association,
that
we
was
can
the
approach.
was why we thought we will have people from the other side, like people from ICMR, from the government agencies, to be there listening to us also what we are proposing. So definitely we will like to have that access, how we can actually gel and incorporate, and we just want to sound them okay, we are serious, we are on the job, and then ask them, okay, this is the body which is trying to do this work, and then how can we actually mix up and come up with something which is quite genuine. And we'll do that. That is there. And just to add on to the discussion, I think by stakeholders, we wanted to know that for collecting or making this registry a success, who are the three allied professionals which we want to actually engage.
So I want to add that one, sir. So there is a possibility of referral bias or enrollment bias, because at least in my center, they get referred only when they develop epilepsy. So developmental delay or central vision impairment, they are primarily seen by developmental pediatricians. In fact, they think pediatric neurology is epilepsy. So how will you include them as a stakeholder, developmental pediatricians?
So that is why we actually have had this question here. So this is
in this group, was it discussed? Okay.
That was discussed, sir. So developmental was discussed. CVI visual specialist was discussed. ASHA workers also discussed. But when you ask three top priorities, there were three top priorities.
So that is why. Otherwise, we'll just have one spectrum, because children getting referred to a neurologist, they will have definitely either a DRE or significant neurodevelopmental delay, but that is not the only thing which is happening here. So that is why we would want, and we wanted your opinion, that we have to actually open the doors to pediatricians, maybe developmental pediatricians, to also bring up data. And that is why we don't want only the tertiary care centers to be there providing us data. We want general pediatricians, people who are single run clinics. They might be seeing the better part of the spectrum. So we want that data to be there with us. Then only we'll be able to say that what true proportion is actually causing a major issue.
So even as a life cycle, we wanted to add even special educators, ADL.
So everything, that we need to actually, for an individual case. For this data, I think we should have developmental pediatricians, we should have maybe neonatologists, we should have a radiologist. So because we will be diagnosing them based on radiology. And if I have to do a sub-study, maybe that person will be relevant for that core study. But we wanted to know, so we'll take this into account.
Prashant, may I add 1 second?
Yeah.
Can
Thank you
hear
so
me?
much. I think, Dr. Nitish, we have, Dr. Vinit, I think we have got the sort of, the gist of it.
Dr. Anas?
Obstetricians, neonatologists, developmental
Dr.
pediatricians. So the three, priority stakeholders.
Dr. Anas?
And we'll further sort of, deliberate on what should be the mechanism of engagement with them. I think there, while summarizing the sort of, position statement, we can clearly spell out what are the mechanisms with which we can collaborate with them. Thank you so much. So invite expert working group 5. Yeah, Dr. Biju.
Yeah, I'm joining.
Dr. Biju sir is there online. Sir, can you hear us?
Yes, I can.
Okay, so I will start. So our group was
Dr.
supposed to
Biju,
answer.
I don't think they can hear us because I was also speaking something. Not here.
Sorry, Doctor, please go ahead.
So we were supposed to answer the question that which 3 international partners should AOCN target during the next 3 years. So for this, we have considered NHBI as the framework, and we have based our suggestions around that. So partner 1 that was identified was Liggins Institute, University of Auckland, because of they have some track record with the child study. So the potential role could be that the investigators from the Liggins Institute, they may be invited as expert advisors or collaborating investigators because of their experienced and masked interstitial glucose monitoring and longitudinal executive function and visual motor assessment. However, a formal institutional partnership should be pursued only if it provides substantive additional value, such as harmonization with the child datasets, access to operational measurement resources, training, external validation, joint analysis, or a grant collaboration. So the second partner that was identified was Center for Perinatal Neurosciences at Imperial College London. So their role would be to establish the imaging,
central review, and longitudinal follow-up infrastructure required for a scientifically credible multi-center NHBI registry. So the potential role for the Center for Perinatal Neurosciences could be that the investigators may be invited as technical advisors or investigators because of their experience in multi-center neonatal imaging and follow-up in South Asia. However, a formal institutional partnership should be conditional on the provisional of clear additional value, such as access to operational imaging manuals and quality assurance procedures, which are not fully available in publications, and harmonization with existing imaging datasets. So the third partner that was identified could be International Neonatal Consortium with the Critical Path Institute, and their role could be to establish the data standards, provenance, verification, and quality framework that is required for the registry to be credible to researchers, funders, regulator, policymakers, and also journal editors. So the potential role could come that they could be valuable to provide technical inputs, mapping to specific neonatal endpoints or adverse event standards, access to other working groups, and an independent review to the registry's provenance and verification framework, the advice linked to regulatory or international case study use, in structured engagement, and training of AOCN teams. So if the collaboration provides only journal advice, which is already available through published standards, then it should be treated as an expert consultation rather than a strategic partnership. The other working groups, the other partners that are potential were identified as ICNA and also ILA or the European Registry Network. So I think most of the fault lines that we had identified, much of this has been cleared over yesterday. There were some additional issues and suggestions that we had identified. These were the mandatory clearance from Health Ministry Screening Committee for any international collaborations, the creation of a MOU clarifying the ownership of registry, authorship, and responsibilities, compliance with Digital Data Protection Act, including consent, anonymity, data sharing with international partners, registry alignment with ABDM, and whether we can utilize the joint ethics review mechanism of ICMR. Okay. So this was basically the gist of what we had identified as the 3 provisional collaborative priorities.
Yeah. So before we open the forum for audience, request Dr. Biju Hamid sir to add further insights. Sir, please.
Thank you. So
can't hear you.
I can hear you. I think it's the tech issue there.
Yeah, we can hear you.
Can you hear me now? Can you hear me now?
Yes, sir. Please go ahead.
Yeah. So what Dr. Minal has just done is an excellent overview of what we had deliberated over the last several days. Just to add couple of things. So essentially, we have identified these 3 partnerships, but these 3 partnerships should be conditional on very clear added value, because international collaborations must strengthen AOCN's capabilities without transferring scientific ownership, without transferring data custody or operational control outside India. So the recommended approach we felt was a minimum viable platform where during the first year, AOCN should establish the essential governance, the ethics, the common data set, and data sharing arrangements, while simultaneously launching a limited pilot in 2 or 3 centers. Because if we don't do that, then the collaborating organizations might lose interest and we might lose the momentum. And then over 36 months, the program then should progress to multi-center enrollment, central imaging review, public reporting of the data quality, the first national analysis, and then we would be in a position to approve like further disease modules. So I think the core principle in terms when it comes to collaboration we felt was AOCN should use the international collaboration to acquire expertise, acquire standards and credibility that will remain under Indian governance and can then support the future national registries. One thing which I wanted a bit more clarity from the working group 3 was, when it comes to registries, when registries often fail when we have the scope as very broad. And NHBI is a good one because it's a very narrow, definable, preventable injury. But the problem there is the hypoglycemia and hypoxic ischemic injury often coexist, and then you can produce overlapping injuries. So if you focus just on the hypoglycemia only registry, then there is a potential risk that we may misclassify. So the argument was whether the the NHBI should be nested within a perinatal brain injury. But this is something which we will have to be cleared with the working group 3 in terms of the definition, the exclusion rules, and how you handle the mixed injury, where there is overlapping HIE and hypoglycemia before we even begin the discussions with our collaborators.
Thank you. Thank you, Dr. Biju. I think you were spot on. You brought the key things that have to be considered whenever you actually go ahead with any form of collaboration. So we'll take all these points, and they were extremely valid. And as far as your comment that is there for these mixed scenarios where it is almost overlapping and it is difficult to actually segregate whether something is purely hypoglycemia or it is a mix of hypoglycemia, hypoxic brain insult. So I think this question was raised and some deliberation has gone in. We will initially we'll try to stick with hypoglycemic rather than on a broader perinatal brain insult, and we'll try to address them by trying to defining it to whatever extent it is possible. But we agree that this is going to be an issue, and it might impair the data that we are going to collect.
Thank you. Thanks, Dr. Prashant.
Thank you so much for those valuable insights, sir. Please, any comments, additional insights from the audience are welcome. On global collaborations. Best.
Opinion of larger group on this.
Yeah. So I think the point is other resource limited countries, can we invite them to be collaborators and contribute to the registry? Is that? Yeah. Yeah. So other resource limited countries, how did they successfully manage establishment and operation of their registries? What can we learn from those experiences and try to incorporate into our registry operations? It is a very valid suggestion. Yeah. Again, any?
That's a good point, because when like for example, Dr. Meenal mentioned about ILAE. Now you may be aware of the Epiphany DRE study, which is a prospective patient-centered registry which is developed in Hong Kong, but looking at the Asian thing, and that integrates longitudinal data, imaging, electrophysiology, etc. So for AOCN, I thought that would be an excellent, highly relevant Asian model for harmonized data elements, surgical referral indicators, etc. Because that was about DRE, but there are common elements in terms of the refractory epilepsy associated with NHBI. Yeah.
Thank you. We'll definitely consider it. It seems to be a valid idea.
I think one more point that we had discussed especially was that in any partnership, we have to see that we become the beneficiaries of actual expertise and not a recruitment side to provide numbers to another international collaborator. Yeah.
Agreed. Dr. Shefali, ma'am, if you are there, if you want to also put a word or two on this, because you have been there collaborating with a lot of international sites.
Yeah, there were two things. One regarding this international one. it's still not simple to make an international registry because there are different rules in different countries about data sharing. So if we have to do with one, but first we should start in India only from AOC, and then later if you want to extend to some anybody, one individual, that would be we'll have to see their rules. And one question, one which was raised, that whether you have to use your allied professional. I wanted to make a point that time. I think I was not audible. I was saying that we will obviously, like we are talking about also the other question Lakshmi Narayan has put it in the chat of the Zoom, because I suggested that yesterday that you should have a hubs and spoke model. So obviously in one particular area you'll identify, and then you'll have ethics centrally as well as of that area, and you cannot have each site made as a person having a clinic or a smaller corporate setup. So they should be all hubs and spoke model that will be discussed, and that can be discussed ultimately firstly in the EB, and then it can be, the thing can be made out. And obviously in that we can't do Ranjit, you were saying you get epilepsy. Yes, you have to involve developmental pediatricians. So each site you have to have your co-investigators from that side. And then obviously that complexity, Lokesh, we'll have to look at it for the publication thing and all later. But like they will have to be partners, otherwise we will not get a holistic data, very rightly pointed out. But we'll have to also keep a mind of the person with pediatric neurology person leading. And even then this we'll have to partner with our neonatologist as well, in this situation, because they also have their high risk newborn clinics. Some of them are following them up to 2 years as well. So I think those things we'll have to keep in mind for having a holistic data. But remember that the lead is the leader is will be AOCN, but they will be partners in any case. Thank you.
Thank you, ma'am.
There is food available. Somebody who's leaving can just quickly have a grab lunch and then go to the airports. Thank you.
Thank you.
Lokesh, have you put it? You are sent through Swiggy to people online. बीजों के लिए कैसे कुछ different करना?
We can have the next group there.
So I think the expert working group number 6 is going to be listing out the advocacy priorities for AOCN, more particular with particular emphasis on NHBI.
Basically ours was more like a summation and a roundup of whatever we've discussed and regarding the advocacy policies. So the first one was, what would be a single policy from the AOCN to prevent NHBI? And there was a lot of debate about the ideal policy and actually the working policy. And so the ideal policy would be, to have glucose monitoring and glucose cutoffs and everything that is standardized by the AOCN and then given to as a national information. But we already have a lot of guidelines and these are not followed. So whether effective training of the healthcare and health associated professionals, right from the grassroots level, if that can be there can be a training policy from the AOCN that might, for the time being, sort of reduce the incidence of NHBI. And some of the tertiary centers could perhaps do a root cause analysis audit where we look into the factors which are, because there are guidelines in place and still we can't implement them. So what are the factors that are sort of hampering those? The enforcing authority would be teamwork between the AOCN committees, the central governing agencies and the nodal authorities, because unless we have the approval from district collectors and others, we won't be able to implement them at a much more grassroots level. So evidence is through collaborative research, and we've discussed so much about it. We need to prove the high disease burden on paper, and only then we can sort of push forward with policies. So key advocacy priorities also, we have discussed consensus guidelines for at least 3 common neurological conditions, including escalation and referral pathways for primary caregivers from the baseline, basically for the baseline workers, and then powering quality research in at least 2 rare conditions such as DEs, and to increase training access. So to widen our expert base, we would like to suggest that there should be training opportunities for as fellowships or observerships, more easy access to those, because the paperwork is quite a lot and a lot of them lose the momentum when they're applying for those. Why now? We have discussed, debated plenty about this, and I think this is quite succinct. 3 fault lines, we've discussed it in the beginning regarding inability to decide on research leads, especially when multiple centers are there, and I think we've already elaborated on those points. Waiting for government funding and lack of incentives, sometimes collaborators and researchers, they lose the impetus to continue with the work. And there was a point that was raised about early feeding. And so we sort of placed this point about rational breastfeeding, where there is so much insistence on exclusive breastfeeding that we expose the child to hypoglycemia. And so this is a double-edged sword. And I think we need to come up with something, a policy that sort of addresses this better. And this was an additional comment. So a multicentric tertiary level NICU project, where we look at what levels of blood glucose is associated with evidence of hypoglycemic brain injury. And that might sort of refine our policy statement better.
Thank you. Thank you for the well-crafted suggestions. So all of them are valid, and we'll definitely try to work upon them. Thank you. So thank you for actively participating. So I think we can have the last comments from Dr. Lokesh.
Yeah, I think today's the meeting was like running a Facebook or Instagram where you created the content. I didn't do anything. I didn't prepare a single presentation, and all of you worked hard to prepare the content and presented it. So thank you, because it's all of our program, not somebody's program, and it's a combined research what we have to do. I'll just share the form for where you show the participation interest, and then if there is any, just a second. Yeah. So we'll go through quickly. It's a very small form. We are going to circulate in the group. If there are any suggestions to include, or you say it's not appropriate in that, then we'll do accordingly. So this is the form. You can, yeah, I think your name, email ID, mobile number, all those standard things. Name of the proposed site investigator or the lead for that site, where the location of the site, approximate number of NHBI patients you'll be seeing in your practice in 1 year. So sometimes it's a difficult challenge if you have paper records. So, but if you have a electronic medical records, it's at the tip of your finger. So that is something you might give an approximation. It may not be an exact number, but a close approximation would be useful. And do you have access to ethics committee in-house, or nearby you have to go to a medical college or some other corporate facility? There are independent ethics committee which will approve your this one. Because it's not a clinical trial, that I think 50-kilometer radius probably doesn't matter here for the practical purpose. So how much time does it take in months to get clearance from studies at your center? Some of the institutes take around 6 months typically to approve a study. So for most of the other ones, probably it should be shorter. So that will be information will be useful. And what is the type of workspace, whether it's a private clinic, group practice, corporate hospital, medical college, or it's a teaching multi-specialty hospital. So that information will also help us to decide the things. And site facilities, tick whatever is applicable. MRI access at 1.5 Tesla or higher with DICOM images, EEG recording with standard reporting. I think training in epilepsy, probably it's not mandatory. A pediatric neurologist is trained enough generally to report his own EEGs. And EEG reports outsourced, where you get only printed records, that's going to be a challenge. MRI outsourced, but you reviewed from outside centers. So we'll have to see, because you might not get, if you're just getting the images, then it becomes a difficulty. Only CT scans done. I think most of us don't do it today. And neonatal electronic records of the same patients where they are now developed will be a huge positive. So I think those centers will be more early recruited on board. Electronic medical records for outpatients. This is another thing. How many of you are actually using electronic medical records? Okay, that's good. There are a few hands going up. So I think that's a way to go, because that's the best way to retrieve and store your information. And a dedicated person available to enter data online. So 20 to 30 minutes, I think it shouldn't require 20 to 30 minutes. Yeah.
Yeah, the core registry should not require 20 to 30 minutes.
10 minutes
Yeah,
probably.
around 10 to 15 minutes is the...
Used to it, 10 to 15 minutes. So in a week, you decide on some day, morning or evening, I'm going to sit for 30 minutes for this in a week, or 15 minutes. So then in 1 month's time, you added 8 patients' data. Okay. So so that is something which we have to have the discipline as like any other part of our life. Will prefer filling paper forms and sharing it after scanning is also completely fine. But that forms will share it with you. But only thing is it will increase the work, but it can be done. It can be same quality of data can be entered. Trained psychologist available to perform the VSMS, MISIC scoring and other assessments in the site, or you get it done regularly as part of your clinical care. Other staff available to conduct parent interviews and assessment of quality of life, or the same psychologist can be doing it. So this information will be helpful for us to see. So what are the things, which centers can be recruited early. Any other information you would wish to share or comment that thing, you can share it. So you're going to share this form in the group today. So and also we'll share it in the not just the group who have come here, in the AOCN official group as well, wherein people who have not attended but want to participate will also be onboarding. So the process of onboarding will start once we have the clarity on the CRF form and we get a institutional ethics committee approval from here. By that time, if we have all the list of centers which want to participate, willingness to participate and commit their time, then we can include the list of their names in the our ethics committee approval. So your centers will already be listed. So it becomes much easier for the ethics committee, this one, whenever you are applying. So that will be useful. So this exercise can be done in next 15 days time. Thank you. I think with which I'll ask Dr. Mohammad Anas to propose the vote of thanks. Thank you.
Thank you, sir, for summarizing today's conclusion. As we come to the close of the first AOCN Research Conclave, it is my privilege to propose the vote of thanks. On behalf of Association of Child Neurology and Yashoda Hospitals, I extend my sincere gratitude and thanks to our distinguished speakers, moderators, panelists, and invited experts for sharing their knowledge and wisdom. I would also like to thank each one of you. As Dr. Lokesh sir had mentioned, and as reflected in our tags, you are not delegates, but contributors to the Research Conclave. Thank you for contributing your ideas, your questions, your experiences, and for enriching this conclave. A heartfelt thank to our title sponsors, CIPLA, and supporting partners, Acrobiotics, NutriGold, and Newberg for their immense support and generous support. We are deeply grateful to Yashoda Hospitals, High Tech City, for hosting this conclave, and for the audiovisual team, the digital team, housekeeping team, registration, security, and all additional supporting staff who have made this a smooth process. Finally, my sincere appreciation to the entire AOCN organization committee for the vision, planning, and dedication in bringing this conclave to life. Thank you once again. We hope today's discussion marked the beginning of many such meaningful collaboration in child neurology research. Thank you. With that, I conclude the session.
I think I'm thankful to Lokesh and AOCN team to recognize that and bring or breach that gap. I think it's a political statement, but sabka saath, sabka vikas, sabka vishwas. I think that's a good foundation to start anything. So great thanks to Lokesh and team. And I think we all can stand up and have a great appreciation for everyone, including Lokesh. Thank you very much.
Thank you. Thank you.
We also have lunch available. Please join us for lunch.
Initial part में आप you were not very well.
I don't.